Thank you for organizer to give me this opportunity to be a part of this nice webinar regarding pregnancy and pregnancy complication. I am Dr. Asad Muhammad Ahmed. I am Sudanese. Now I am working in Gulf Medical University in UAE as associate professor in medical lab science. My background is medical laboratory science. Today I need to share with you here some of our study conducted before 1 and 2 years ago among Sudanese people or Sudanese women who are suffering from recurrent abortion. Our study, it's belong to study association between factor V Leiden, prothrombin, and methylene tetrahydrofolate mutation gene with recurrent pregnancy loss among Sudanese people. This is our presentation. This is my presentation part. Start with introduction, objective, our material and method, result discussion. Then we will can go brief about some limitation or some difficulty which are faced us during we conducted this study. Then our conclusion and some of recommendation according to our experience from this study. As we know, recurrent pregnancy loss now it's become very common, and according to statistical worldwide, 23 million of pregnancy loss of their pregnancy, and it's counted about 10 to 15 problem of each pregnancy. If we need to go to brief, what is recurrent pregnancy loss? Actually, it lost the pregnancy before complete 24 weeks of gestation. Inside this loss, we need to go and define recurrent pregnancy loss. And when we can say this is recurrent pregnancy loss. Recurrent pregnancy loss, it's defined as 3 or more pregnancy loss. And here we face many issues regarding this number, because according to the standard and our objective, we need to include any woman who have 3 or more consecutive pregnancy, because sometimes we found 2, but she have one successfully passed the third one. Then we exclude this. This it's become our including criteria very restricted and very difficult, because as definition, it should be 3 or more pregnancy loss. And this it affected about 1 to 2% of women. Each woman, married woman, they suffering 1 to 2, they suffering from recurrent pregnancy loss. According to the causes of recurrent pregnancy loss, there are many causes that it can lead to fail the pregnancy, or the pregnancy it lost before it complete 24 weeks. The most common are chromosomal abnormality, endocrine disorder, immunological disorder, and thrombophilia. And also the secondary causes or other causes related to lifestyle, like smoking, obesity, and drinking alcohol, like this. Okay, but unfortunately, most of recurrent pregnancy loss, it's unclear or remain unexplained. This is regarding the causes. We focus in our study more related to thrombophilia, because why we selected thrombophilia in Sudan? because it's not no study conducted more related to thrombophilia or investigates the causes of thrombophilia among Sudanese pregnant women. Okay, there are many other disorders they investigate more, like parasitic infection, immunological disorder, and other. It seems like it's covered, but no more investigation run related to thrombophilia. And here in thrombophilia, we focus more in antithrombin 3, protein S, protein C, and factor 5 Leiden, prothrombin mutation, and factor 8 lipid, and methylene. Why we select these in thrombophilia? Because these are related to blood coagulation. It can make imbalance in blood coagulation, and finally it can lead to clotting mechanism, and this it can be or counted risk vascular complication in pregnancy, especially when the placenta start to form. Finally, we have problem related to bleeding or related to thrombosis. This is our aim of study. We conducted this study to investigate the correlation between factor 5 Leiden, prothrombin, and methylene among recurrent pregnancy loss Sudanese women. Because why we selected these 3 genes? Because we searching more about the causes or the study conducted in Sudan. We found many studies conducted related to immunological causes, infection causes, and other causes. But these factors are not fully covered. There are some studies conducted same this factor, but among people suffering from recurrent thrombosis. But this is our first report, this is our first study conducted among Sudanese women who suffering from recurrent pregnancy loss. Studies factor 5, prothrombin, and methylene. Also, the prevalence of these among control and group, we can see this is statistically significant. Any statistical significance between case and control or not. Here is our study design, and regarding study design, there are many issues regarding study design, not in our this research, but in most of research. Because some people, they confusing between retro and probe. Okay, some people, they said retro related to collecting data, and some people related this according to disease, occurrence of disease. If you search before disease, this is pro. If after, this retro. After we searching more and more, we found the best study design for this is retrospective, because we searching for mutation, and mutation already inherited for those women. And we follow them with case control. That's why we select a retrospective case control study. Here our study population, we including 100 Sudanese women who have problem with recurrent pregnancy loss. And actually we target more than this number, but when we come according to including and excluding criteria, we face many difficulty regarding to complete this number. And in last months, we after we consultation or obstetric supervisor, they said we can include women who have 2 pregnancy loss, because if we include 3 pregnancy loss, it's difficult to find or to complete our target population. Also, we include 94 healthy women, this as control in our study. This is our inclusion criteria. We include each woman who at least 3 or more consecutive pre-pregnancy loss. And the most important factor here, it must be unknown causes. We have, I remember that we have one lady, she lost her pregnancy more than 10 times. But she said already she diagnosed, we are not included in our study because her cause, it's become known. According to exclusion criteria, we exclude each woman had known causes of recurrent pregnancy loss. Regarding ethical issue here, we follow all ethical issue related to Umdurman Maternity Hospital because this study was conducted among patients who attended Umdurman Maternity Hospital, and this is the biggest maternity hospitals in Umdurman. As we know, Khartoum as capital, it's divided into 3 parts. Okay, this is here we conduct our study in Umdurman city. And also we meet all criteria requirement for ethical approval committee, and we got a final IRB from hospital IRB and research ethical committee before we start and meet our patient. This is our methodology. After consent, we met women and we inform them about study title and objective. After that, they consent and we take consent form from patients. Then we collected sample, and this sample we use white blood cell as source for DNA. Then we use for detecting factor 5 Leiden, methylene, and prothrombin, a specific primer for each gene, and we use a PCR specific primer for each one. If we see here, this primer, forward and reverse primer for factor 5 Leiden, this forward and reverse primer for prothrombin, and this is forward and reverse primer for methylene. And we face many issues regarding this primer because unfortunately we have no any manufacturer in Sudan design this primer. We requested this from outside. We wait like 2 to 3 months. Then we start our work. Then we found this primer. It's expired, or there are some problem related to transportation, heat, store temperature like this. We're suffering more regarding this issue, and I think this is the one causes of why these studies are not fully covered in Sudan. Regarding our data analysis, we use SPSS version 27, and we consider p-value less than 0.05 as a significant value. This our result in our study include 194. This include cases uncontrolled. Here we have, as we mentioned before, 100 experienced women, or they have problem with recurrent pregnancy loss. And here 95 women with control. Actually, we collected 100 control because it should be equal. If equally, it's fine. But when we start the extraction and centrifugal processing our sample, we lost about 6 samples. And here we need to report this clearly about 94 samples. This is about age criteria. We have we classified patients according to their age into 4 or 5 groups. The majority of group lying between 30 to 34, and the less it's more than 40, because in Sudan the ladies they married early, and rarely we can see some delivery after 4 years. That's why we found here the less number or about 90 12% about women who have more than 40 years old. Also, we assorted here time of recurrent pregnancy loss according to the age group. Here, if we remember in the presentation, we take pregnancy when we face some issue regarding the source of our sample, because first we searching about women who had 3 consecutive pregnancy loss. Here why we take twice, or women, we include women who have 2-time pregnancy loss, but the number it's not more, it's not much. Here is twice, about 10%. Here 3-time, also 4 times, 5 times, and 6 times, 7 times, 8 times, and this according to the age, more than 30 and less than 30 years old. We can see here the majority of our sample lying here is 3 times. If we see more than 30, it's about 69%. Less than 30, it's about like 55%. This maybe indicate more age, that means more, maybe more complication, more delivery or pregnancy complication. Here is our distribution of factor V Leiden. We can see here we found among cases about 8%. We found 80 individuals who had positive factor V Leiden, showing, because we have 100, showing like 80%. Also among our control, we had 6 positive out of 95. It's showing like 6.4%. This is our allele, about G and E allele. That we classify those according to heterozygous and homozygous. And here this is our amplification band for factor V Leiden mutation after gel electrophoresis. And also regarding frequency of prothrombin, we found 3 positive genes among our cases. And also here we have not detected any mutant gene among our control group. Also here we classified this gene according to homozygous and heterozygous. And this is PCR amplification prothrombin gene after we use enzyme and run gel electrophoresis, and this is a band, and this is the number of cutting according to base pairing. Last, we have methylene, and the result is coming similar like prothrombin. We found 3% in case, and there are no any mutant gene detected among our control group. And all statistical significant when we compare case and control regarding the 3 gene, we found all B value are not statistically significant. That means our B value more than 0.05. Also, this is PCR amplification of methylene tetrahydrofolate gene. Here, this is our part of discussion. We compare our study finding with some study conducted outside, because we have no any study conducted in Sudan according to our database, because this is really it's challenge here. Study connection between factor Leiden, prothrombin, and methylene, and any molecular in Sudan seem like a killing because most of the enzyme, primer, and any tools related to molecular should be requested from outside. Then there are many change during transportation, storage, internally transportation, store may be altered because all molecular items very sensitive. When you talk about primer, about enzyme and other reagent. Really, it's a challenge, and there are many causes make this challenge. Maybe according to facility among patients, because if the patients they need to go to private to request this, it's very expensive because most of them they take sample and send the sample outside for investigation. That's why maybe most of patients they are not looking, or most of physicians they are not request molecular study for those women. Number study they have highlighted thermophilia gene as primary factor. When we searching, we found that many studies they found that thrombophilia gene it's primary causes for recurrent pregnancy loss. As we said, this is the first documented of prevalence of factor V Leiden, prothrombin, and methylene among Sudanese women. There are few studies conducted among patients who are suffering from thrombosis or recurrent thrombosis, DVT. But among pregnant women, this is our first report. The finding of our study, it's line with many number of study, like some study conducted in Saudi Arabia. They found that this gene, they did not show any association with recurrent pregnancy loss. And some studies they agree with us. This has no any statistically significant or no correlation. And other study they found that there are strong correlation between this factor and pregnancy loss. Also, this finding agree with some study in Palestine, among Palestine women. They failed to find any significant correlation between this factor and recurrent pregnancy loss. Also, in other side, our study is disagree with many studies that found that there are link between this factor and pregnancy loss. Here, some study conducted among Syrian women. They found that methylene, factor V, and prothrombin, it's showing observed significant rise among women who are suffering from a study. Also, in Syrians, there are some study conducted also same and found that they are high risk for pregnancy loss among women who have or diagnosed with this factor. Also, another study conducted in Saudi, they found that factor V and prothrombin and methylene were significantly prevalent among Saudi women who are suffering from recurrent miscarriage or recurrent pregnancy loss. Here in our conclusion, we have low prevalence, and this low prevalence of factor V Leiden, prothrombin, and methylene among Sudanese people don't play a role in pathogenesis. And the most thing which confusing by this, when we found mutant gene among among our control, because when we include our control, we include our control healthy woman with at least 2 normal pregnancy and delivery. Okay. Also among those, we found some, especially factor 5, we found about 6 patients, 6 normal controls, they showing positive, maybe due to like technical error, maybe reading of mutation, or maybe this factor has no role in pregnancy. We are not sure. Here we have some limitation in our study. Actually, we face some difficulty regarding inclusion women to include more number because that's why we can see sample size it's relatively small because our study has short period and also factor which you put for including criteria 3 consecutive pregnancy loss. It's so difficult to find high large number with this criteria. Also, this finding may be not applicable because our sample it's very less, like 100 sample, and we conducted this study in single center or single hospitals in city, and we cannot generalize this to population or Sudanese, other Sudanese women. Also, various variable which link for recurrent pregnancy loss are not assessed. Last year, we have some treat or some recommendation for who plan to conduct any research related to thrombophilia. Here, further research focusing on large cohort Sudanese women.
Dr.
It required.
I would request you to wind up, please, because it's way past the 20 minutes of the slot allotted.
Yeah, only 1 minute, alas.
Yes, it's, yeah.
Okay. A more prospective study, it need, we are not need to conduct the study after woman lost pregnancy. That's why we need to search early or before marriage, it's fine. Also, we found many, when we come to discussion, we found many causes related to factor 13 and factor 11. Also, increase healthcare professional awareness, also enhancing women understand of this factor, because we found some women, they not worry about this and say, what's this? If it's showing positive, what it mean? If it's negative, what it means? Then what I do like this. These are our selected some reference, and thank you. And because it's expected to exceed my time, I put my contact here number, email, and WhatsApp. If you have any query, any question, any collaboration, you are welcome.
Good morning, everyone. I'm Dr. Al-Haj, Sudanese from Saudi Arabia, and I will be presenting to you a case report of a coexisting chronic ectopic pregnancy and appendicitis. So, starting with the introduction of our case, usually the ectopic pregnancy describes the implantation of the gestational sac outside the uterus. Whereas its incidence is in UK about 11,000 pregnancies. On the other hand, the chronic ectopic pregnancy is an uncommon condition that is brought about by the implantation of the trophoblastic tissue in the fallopian tubes, which may result in the prolonged tissue deterioration at the attachment site. Usually in the chronic ectopic pregnancy, the chorionic villi are scarce. That's why usually the patient present with a low or undetectable serum beta-HCG. This is in contrast to the ectopic pregnancy, which usually the patient present with a high HCG more than 1,500 to be diagnosed. Because of the biochemical markers and the imaging modalities are inaccurate in the diagnosis of chronic ectopic pregnancy, it often presents as a unique diagnostic difficulty for clinicians. These are the sites for the ectopic pregnancy. Usually the ectopic pregnancy implantation site, it may occur either in the most common part for the implantation is the ambulatory part. It may be implanted in the peritoneum or in the cervix or even in the abdomen. Regarding our case, We had a patient who is 28 years of age, Indian. She presented to the emergency department with a right-sided lying pain for 1 week and vomiting for 1 day. The pain was squeezing in nature, which was increasing in intensity over time for 1 week. Regarding her obstetric history, she is a para 1+1 with a history of cesarean section 3 years ago, and she had a history of miscarriage, which was treated medically 2 weeks ago in another hospital. Since her treatment of miscarriage, she had an irregular vaginal bleeding. She had no history of contraception. She had no history of pelvic inflammatory disease or sexually transmitted illnesses. Regarding, she has no medical or surgical history of concern. On examination, the patient had normal, she looked unwell, but with the average vitals, her pulse rate was 92 and the blood pressure was 100/70. Her respiratory rate was 20 and the temperature was 36.9. Abdominal examination confirmed tenderness maximum in the right iliac fossa with a positive rebound tenderness and a mild tenderness in the left iliac fossa as well. The gynecological examination revealed a closed cervix with the right adnexal cyst. Investigations ordered, including the complete blood count, which showed high total white BCs 13.8 and hemoglobin of 9.9 gram per deciliter and a platelet count of 194. The pelvic ultrasound was done, which showed an empty uterus with a right ovarian cyst of 3.28 centimeter with a mild free fluid in the pouch of Douglas. A CT scan of abdomen and pelvis revealed a dilated thickened appendix. At this point, a diagnosis of appendicitis was confirmed by the surgical part or the surgical department, but we had some suspicion of an ectopic pregnancy, although that the HCG was low. So we proceeded immediately for an laparotomy, an exploratory laparotomy with a subumbilical incision had been done. We surprisingly found that a ruptured tubal chronic ectopic pregnancy with necrotic tissue and free fluid occult blood, about 50 ml in the peritoneum. We had already, we also found that there was an enlarged inflamed appendix. So immediately a right salpingo-oophorectomy along with the appendicectomy was done. Evacuation of the blood clots was done as well, and the surgical drain was fixed. Upon exploring the left ovary, there was also a ruptured left ovarian cyst, so a left cystectomy was done as well. Biopsies were sent for histopathology. This picture showed showing the right ovarian cyst, the ultrasound. Post-operatively, patient was admitted for 3 days on intravenous antibiotics and fluid, and the surgical drain was removed 48 hours later on. The patient was followed in the outpatient clinic. The histopathology results came showing a right fallopian tube with chorionic villi, consistent with the tubal pregnancy, and inflamed appendix as well. Left cystic fibrous with hemorrhagic inflammation and granulation tissue, cystic, confirming the cystic ovarian cyst on the left side. Going to discussion of this case, the abdominal pain is a very common presentation. It accounts about 5 to 10% of cases which are presented to the emergency department. The most common cause of surgical pain in pregnant patients is appendicitis, which has an incidence of 1 per 2,000 pregnancies. Ectopic pregnancy occurs in 1 to 2% of all pregnancies. The incidence of chronic ectopic pregnancy was found to be about 20.3% of all ectopic pregnancy. The association between the appendicitis and ectopic pregnancy is a quite rare association. It has been reported in only 23% of cases from 1960 till 2008, and several cases thereafter. So what is the pathophysiology of the appendicitis? The appendicitis, there is usually no definitive or single theory that's reported to diagnose or to give us that clue about the pathophysiology of appendicitis, but a combination of the luminal obstruction and or the infection have been both postulated as the most probable causes. Regarding the obstruction theory, which is caused either by the fecalis or lymphoid hyperplasia. The appendiceal wall ischemia which results in increased intraluminal pressure, which may result in the appendicitis. Whereas, according to the infection theory, the pathophysiology of appendicitis begins with mucosal ulceration of the appendix, which is then followed by secondary infection from the normal colonic flora. These infections can be bacterial or viral and can result from processes like the colitis or the gastroenteritis that are close to the appendix. What are the association between the pathology, and if there is any association? We have been digging about if there is an association between the appendicitis and the ectopic pregnancy and which had led to the other, or it may be a coincidental event. Many theories have been adopted between these about this association. According to some writers, they have been telling that the appendicitis or history of appendiceal surgery may cause short or long-term nearby inflammation of the fallopian tubes, which can increase the risk of developing ectopic pregnancy later on. On the other hand, some writers contended that ectopic pregnancy may trigger the appendicitis through a combination of the initial inflammation and the secondary infection leading to the appendicitis. It suggested that ectopic pregnancy may induce contiguous inflammation, leading to periappendicitis and then appendicitis. This leads to mucosal sloughing and creates a portal for the infection in the appendix by the normal colonic bacterial flora, which seems to happen in this case. Previously reported cases of chronic ectopic pregnancy, concurrent ectopic, and appendicitis have indicated that the right tubal ectopic pregnancy, 75% versus a left tubal ectopic pregnancy, means that there may be some association between the right ectopic pregnancy and the appendicitis since it's located in the right side. These observations are consistent with the possibility of interrelation between them. In our case, the patient presented with symptoms of right iliac fossa, repeated vaginal bleeding, and a positive rebound tenderness, and a positive low SCG, along with a vague misleading history of a treated miscarriage, which made it difficult for us to have a definitive diagnosis. That's why we proceeded to the laparotomy. It's recommended by the authors that if there is uncertainty of a diagnosis, like in our case, an emergent diagnostic or therapeutic laparoscopy or laparotomy according to the patient condition and the experience of the operator is recommended. To conclude at the end, although it's a rare incidence, but the combination of a chronic ectopic pregnancy and appendicitis have been reported many times in the literature and should never be missed. And early diagnosis and management are important in such conditions to avoid maternal morbidity and mortality. This case is different from what has been reported in the literature before, as a chronic ectopic pregnancy have never been mentioned previously with appendicitis. These are my references, and thank you for watching. As we said, that more than 90% of people more than the age of 15 have the immunoglobulin, the varicella immunoglobulin antibody, and they are seropositive, means that they had the infection maybe in their life earlier. The incubation period is usually about 1 to 3 weeks, and the illness usually spread 48 hours before the rash showing the sun appears, until the vesicles crust over. Usually the vesicles crust over in about 5 days. Fever, the patient usually present with fever, malaise, and some pruritic rash that may turn up into maculopapular crops and usually become vesicular and crust over before the healing, which are these signs make the hallmarks of the initial infection of the varicella zoster. Usually, if patients got infected with the varicella infection during pregnancy, can spread to the fetus through the placenta. A fetal varicella infection can result in a widespread fetal illness, which we call it the congenital varicella syndrome. And the fetus is, but usually the fetus is protected by the vaccination that the mother can take it before the pregnancy. Usually this vaccination is completely contraindicated in pregnancy. In nerval tissue, the varicella zoster become latent at the primary of infection. Means that if the patient got the chickenpox earlier in their life, the virus become latent in the dorsal root ganglia, in the cranial nerves, and in some other autonomic ganglia in the enteric nervous system, and some astrocytes. The majority of cell-mediated immunity regulates the varicella zoster virus latency, and its loss is thought to be the cause of this reactivation of this virus. The varicella zoster virus replicates inside the neural and cell bodies during the reactivations, and these virus particles are released from the cell bodies and travel down the nerves to the corresponding dermatome. The virus causes vesiculation and inflammation in the affected dermatome, and the inflammation of the varicella zoster affected nerves is what causes pain that is brought about by the herpes zoster. Herpes zoster usually is developed globally and does not vary in the frequency seasonally, because it's almost dormant in the nerve tissue, and as we said, it becomes reactivated with the loss of the immunity or the people get older. The frequency of the herpes zoster varies based on age, ranging from 1.2 to 3.4 per thousand individuals annually in younger adults, to 3.9 up to 11.8 per thousand individuals annually in older individuals, means more than 65 of age. Zoster rash is a primary indicator of the herpes zoster. However, in some cases, we may need to do some investigation like the PCR or the enzyme immunosorbent assays. Subacute herpetic neuralgia, usually the most sensitive or the most marker of the herpetic or the zoster infection is the herpetic neuralgia, and the post-herpetic neuralgia are the main side effect. Some patients may present it with complications like disseminated herpes zoster, the zoster ophthalmitis, and some secondary bacterial infections as well. Some patients as well may present with gastrointestinal or renal problems. And the morbidity and the mortality are linked mainly to the herpes zoster vasculitis. So coming to our case, we had a patient who is in her 31st of years of age. She presented to the emergency department with left side abdominal pain for 3 days. The pain was severe and throbbing in nature, throbbing and burning in nature continuously all the day long. She had no fever, she had no change in bowel habits or any urinary symptoms. She did not mention any symptoms on any history of similar condition before. Regarding her obstetric history, she was a gravida 6 but a 4+1 in her 6 weeks of pregnancy. Her first delivery was a caesarean section with 3 successful vaginal births after caesarean section. Regarding her medical history, she is known to be hypothyroidism, for which she is receiving thyroxine 50 milligrams. She is not to have any allergy. Her surgical history, she had no surgical history of concern apart from the caesarean section. On examination, her vitals were normal. Her pulse rate was 48/84, blood pressure 120/75, and temperature of 36.8 Celsius. Obstetric examination, she had a fundal height of 33 weeks, longitudinal live fetus with a cephalic presentation and positive fetal heart. She had no apparent abnormality noticed in her abdomen. Investigations requested showing a complete blood count of a hemoglobin 11.5 gram per deciliter, total white BCs of 9 times 10,000, and a platelet of 250 times 10,000. The urine analysis showed bus cells and ketonuria. At this point, we had an initial diagnosis of urinary tract infections. So immediately we started the management with an IV antibiotics, the analgesics, and hydration. Despite of these medications, the patient was not improving at all, despite of the mild analgesics, to a severity that the patient was not responding to the mild analgesics. We had to give her a pethidine to relieve her pain. We had some suspicion of ureteric stone. That's why urologist was informed as well, but the ultrasound was clear, and we continued with the medications. At that time, the patient developed a papular rash at the T11 to 12 dermatome. At this point, it was very obvious that this is a herpetic rash, shingles, and the diagnosis was made initially, and then we started the treatment with antiviral medications, including the acyclovir 800 milligram tablets 5 times per day, analgesics, topical acyclovir, and calamine lotion were prescribed to relieve the symptoms. The patient's symptoms improved with time, and she was discharged after 5 days in a good condition. On her follow-up in the outpatient clinic 1 week later, she reported less pain and the lesion started to cross. 2 weeks later, she presented with a labor and she had a successful vaginal birth after cesarean section. The outcome was a healthy baby girl with average weight, and the baby was examined by the neonatologist and confirmed no evidence of rash was noticed in the baby with a healthy baby girl. This is the initial rash that appear on the abdomen, which is an erythematous rash at the 11 to 12 dermatomes. And this is after the vesicles started to appear 2 days later. After we started the treatment, in 1 week, the lesion started to cross and the pain, of course, started to subside, and lesions start to heal at the last picture. It was very obvious these lesions started to healing without causing any remnant parts. So in general, the relationship between these two diseases have been understood more than 100 years, and it's based on the observation varicella zoster remained latent in the human neuronal for decades after the varicella infection, and sufficient varicella zoster specific cell-mediated immunity is needed to maintain latency, and the loss of the cellular immunity lead to activation of these herpes zoster virus. About 70 to 80% of herpes zoster report prodromal pain in the dermatome, which is followed by the appearance of the skin lesions. Each patient may experience pain differently. They may present with a burning pain, the shooting pain, the stabbing, or even the throbbing pain. Mostly of the pruritus, mostly pruritus. Others may experience only discomfort when the area is touched. The prodrome usually started 2 to 3 days on average. Prodromal pain is severe that can last for a long time, frequently prompts a doctor to look into other conditions or other differentials like the angina, the cholecystitis, the glaucoma, if it was involving the dermatome of the eye, or the vesicular or the ophthalmitis, the nephrolithiasis, or spinal nerve compression. These prodromal signs we present in our patient, which have made it very challenging to diagnose or detect the condition right away, as no lesions were apparent at that time. However, the diagnosis was obvious as soon as the rash appeared, and the patient started treatment immediately. Since T10 to L1 dermatomes are the source of the uterine sensory nerves, there is a theoretical risk only that intrauterine infection during pregnancy after the herpes zoster involving these segments. Nevertheless, there have no reported data or no recorded reports of this type. Herpes zoster infection during pregnancy is not associated with any increased risk of congenital malformation above the general population baseline risk of congenital varicella syndrome. Up until recently, the standard care for herpes zoster during pregnancy had involved administering antiviral medications or taking acetaminophen on a regular basis for the pain. Despite the paucity of research on the safety of antiviral medications during pregnancy, a number of studies indicated that the fetus is not significantly affected. Antiviral medications are recognized as category B for expectant mothers, and the acyclovir and valsarclovir are advised. Pregnant women should not receive varicella or zoster vaccines as a preventive measure. It should be advised before the pregnancy. It's crucial to counsel the women who are not immune about the varicella to stay away from the varicella zoster exposure, and individuals with herpes zoster should cover their lesion to reduce the risk of transmission of the varicella zoster virus to other susceptible women. To conclude, in contrast to the chickenpox, herpes zoster during pregnancy does not raise the risk of congenital malformations above the average for that group. To lessen the chance of spreading the varicella zoster virus to the vulnerable pregnant woman, those with herpes zoster should cover their lesions. This is the end of my presentation, and these are the references. Thank you for attending.
Yes, hello everybody. I'm very pleased to have this opportunity to share my research with you in this floor. I'm going to present research about effect of obesity in male fertility, which conducted in Sudan to 2020. First of all, I want to talk about obesity. What do we mean by obesity? It is a medical condition characterized by deposition of excess body fat in the body, which adversely affects the health and reduces the life expectancy. Why we usually have obesity? Mostly associated with hormonal disturbance, which can adversely affect our function. Obesity, it could be according to BMI. People are classified as BMI 25 to 30 as overweight people, and those who have BMI more than 30 are classified as obese, and those of more than 35 BMI are classified as morbidly obese people. About the obesity and the male fertility, there is many literatures about this, discuss this issue. It was found that decreased testosterone level and increased estrogen level, which decrease the testosterone estrogen ratio. This can cause great change in both spermatogenesis and other aspects of male reproduction. Resistin and hyperinsulinemia, which usually be associated with obesity, also had inhibitory effect in spermatogenesis and reduced sex hormone binding globulins. There is globally noted that there is high increase in the rate of male obesity all around the world, and deposition of fat in the scrotum. Also, they found it causes heat and it affects the spermatogenesis. This nice picture explains this is obesity, and which is caused many physical disorders, genetic disorders, hormonal disorders, all of this. And these all can cause erectile dysfunction, which alter the semen parameters and result in subsequent subfertility, male subfertility. Another nice picture also explaining the effect of adipocyte in the function. It was found that high adipocytes, that means high fat, can affect physically. It can cause the erectile dysfunction, increasing the scrotal temperature, and as I just mentioned, it affects the spermatogenesis, also causing sleep apnea. Also, this can affect and disturb the testosterone level, which is also very important for the spermatogenesis. It also affects the seminal parameters, including azoospermia. It can cause azoospermia or oligospermia and reduce the semen volume. Also, hormonal change, increase estrogen and reduce testosterone, in addition to increasing insulin and leptin, as I just mentioned, they all reduce the spermatogenesis. This is another nice picture that explains the negative effect of high estrogen in the testis and spermatogenesis, in addition to the low testosterone level, have also negative effect in the spermatogenesis. This study was conducted because many studies have studied the effect of obesity in female and whether weight reduction can reverse the fertility. So there is shortage in such studies in male, and as I mentioned, there is high rate of obesity among male all over the world, and there is high rate of obesity. So we need to encourage such researches regarding male obesity and fertility. The objective of this study was to investigate the effect of obesity in male fertility, and specifically whether this obesity had effect in the spermatic parameters, morphology, motility, concentration among obese male, and whether the obesity can affect the erectile function, and to assess the association between the personal characteristic, age, comorbidities, and infertility. It was a cross-sectional study, hospital-based, facility-based study conducted in Banun Infertility Center, which is one of the largest infertility center in Khartoum state. Average number of patients seen per year ranging from 1,500 to 2,000. Benoon Infertility Center represent private sector in Khartoum state. Study duration was 6 months. It started from January to June 2018, and study population was all male with infertility came to the infertility center in the study duration. The sample size was about 195, and it was by total coverage. That means we obtained all the infertile male that came in the study duration in the study area and agree to participate in the study. Inclusion criteria, all male couple married for 1 year or more and has no siblings, male with primary or secondary infertility. Exclusion criteria, all males that have any confounding factors like comorbidities are excluded from the study, and also those who didn't like to participate in the study. Independent factors including the age, the ethnic group, the BMI, and dependent variables including the spermatic parameters, oligospermia, azoospermia, abnormal sperm morphology, abnormal sperm motility, or erectile dysfunction. Data collected through questionnaire involving or reflecting all information about the sociodemographic data of the male, if any medical condition male have, or the any sexual dysfunction have, and also information obtained from the clinical profile of the male, including the spermatic analysis and also BMI of the husband. Data analysis data was analyzed using SPSS, was used for analysis of the data. Ethical consideration, first of all, research conducted after obtaining ethical approval from the center, the infertility center, all men including receive written informed consent, and they are well informed about the study purpose of the study, and also questionnaire filled by the male confidentially, in a confidential way, and also every male participant in the study was informed that he had the right to withdraw from the study whenever they want, and there is no mention of any name of any participant in this study. According to literature and background of this issue, we expect to find a great association between the obesity and the male fertility. However, there is some limitations that we face during this study, including the limited number of the participants, and this is because of the limited duration of the study. So hopefully more studies will be done in the future, including larger sample size that can truly reflect the community. According to the age, from the study group, it had been found that more than 40 years old represent 50% of the study population was more than 40 years. And where is the screen? And regarding the ethnicity, most of the study population were from northern Sudan. About body mass index, most of population, more than 80 or 90% of population have BMI of 25 to 30. Regarding the spermatic count, it has been found that oligospermia was found in 38% of the study population. And also regarding the morphology, among this study population, 46.2% were having abnormal spermatic morphology. Regarding the motility, 51% of the study population have sluggish motility. This is multiple regression explaining the BMI and seminal parameter. for the study population. This represents the male with erectile dysfunction was only 29%, comparing to 71% of study population that they didn't suffer from erectile dysfunction. It had been found that by increasing the age, most of the male, they used to gain weight, and most of obese male, they age more than 40 years old, which is associated with a reproductive problem for the most of the male. So increasing the age increase the risk of obesity among male and increase the risk of infertility among these males, and this is supported by many studies. Furthermore, most of the participants, about 53%, were from Northern Sudan, followed by participants from Eastern Sudan. This is what we explained, and actually it was found that there is no ethnicity significant effect in the obesity among male and infertility. 81% of the participants were of BMI, as I just said, between 25 and 30, and this is approved by other studies, which demonstrate or confirm that most of the obesity among male this is overweight. This is regarding as overweight, and most of male, they came suffering from this age to from this BMI. Sorry for this. So starting from BMI, having BMI 25 to 30, they have moderate effect in the infertility, and comparing to those who have BMI more than 30, they suffer more and they have more risk to have infertility. Also, these people have been studied for the spermatic quality and physical and molecular structure of the germ cell of the sperm. It was found that not just the spermatic parameter have been affected regarding the motility and morphology of the sperms. However, also the genetic structure of the sperm itself, it would be affected. That means this male will not just suffer from subfertility, but also there is high risk of miscarriage due to poor quality of the sperm if pregnancy occurred. Another study done in 2016 in UK stated that the sperm quality of men whose BMI was over 25 was significantly decreased and even more severe in men whose BMI over the 30. And this is just, we said this. One of the big risks for fragmented sperm DNA is there is increased risk of early miscarriage. Infertility is a silent problem that obese men have to face. So this is a big health issue that it should be addressed, and it should take the attention of the policymakers and the media. Okay, this is confirmed what we just said, the effect of obesity in the progressive motility. We have found that 45% have affected progressive motility. Another study done in USA in referral clinic stated that the incidence of oligospermia increased with increasing BMI. Also, another population-based studies conducted over the past 5 to 10 years have indicated an increased likelihood of abnormal semen parameter among overweight and obese men, and the potential increased chance for subfertility among couples in which the male partner is obese. Also, it had been confirmed by several studies that it has been found in obese men, they have high level of leptin and estrogen level, which, as we just said, affect the spermatogenesis of the male or obese male and reduce the testosterone level, which in turn also cause further reduction in the spermatogenesis. So there is clear association between obesity and male infertility, and although there is clear reduction in the progressive motility of the sperms, the linear regression of this study showed no significant association as p-value was only 0.3, and as showed in histogram. This is histogram I just saw. And this mostly due to, as I said, there is limitation of suboptimal sample size, which is limited by the study duration. So after all, we conclude that increased age of male patient increase the risk of infertility because we've also increased the risk of obesity. Ethnicity has an unclear effect in infertility. There is increasing rate of obesity among male in Khartoum, and obesity affects the seminal parameter, especially the motility, which is clear in this study. Obesity has a role in erectile dysfunction. Despite that, the most literature had recognized that obesity is a risk for infertility. This study failed to identify that statistically significant difference. This could be explained by the optimal sample size we had. So we recommend to conduct this study using larger sample size. That could be more reliable. We recommended that encourage early marriage to avoid infertility problem associated with increased partner age. Community education to encourage healthy lifestyle by participating regular exercise and healthy dietary intake to avoid obesity and associated comorbidities. More studies in this area will have very good impact in infertility. Thank you for listening. That's all what I have regarding this. Hello again, and thank you for giving me also this opportunity. This actually is a case report for use of oral methotrexate and misoprostol in the treatment of cesarean scar pregnancy. This case report was identified or noticed in Jabaloulia Teaching Hospital in Sudan 2016. First, let me tell you about the cesarean scar pregnancy, which is defined as pregnancy in the previous cesarean scar. It has high risk for severe maternal morbidities like uterine rupture, hemorrhage, or even if continue to live birth, it could be complicated by placenta accreta spectrum, hemorrhage, and risk of cesarean hysterectomy. There is also high risk of recurrence, and it is estimated by 17% of patients they have cesarean scar pregnancy. They are on risk to have recurrence of the case. Whenever a patient diagnosed with cesarean scar pregnancy, observative management is not recommended by the Society of Maternal and Fetal Medicine. Several treatments and combination of treatment for cesarean scar pregnancies have been reported in literature. However, the optimal treatment is still unclear. The Society of Maternal and Fetal Medicine Consult Series recommendations for the treatment of cesarean scar pregnancies included active management with operative resection, ultrasound guided section dilatation and curettage, or intragestation methotrexate with or without other modalities. Mifepristone is usually used in combination with misoprostol for abortion management, and it is another drug that may be used in cesarean scar jointly with other methods, although it is not described in the Society of Maternal and Fetal Medicine Consult Series. The objective to the case report, the patient we have was 39 years old. She was gravida 5, bara 4. All previous deliveries were by cesarean section. Last one was 2 years ago. The patient presented with amenorrhea and was found to have positive urine pregnancy test. It was unplanned pregnancy, but it was the third one. At 7 week, patient give appointment for her first TVS at 7 week, and it was found that there is a gestation sac corresponding to the date of 7 week with positive fetal heart, viable baby, that is to say. However, there was concern for the implantation of this gestation sac in the cesarean scar, which indicated cesarean scar pregnancy. This is a picture of the patient. I think it is very clear the endometrial line at the fundus is very clear line. However, this is the gestation sac located at the site of the previous scar. Patient was counseled about the diagnosis, and this is a cesarean scar pregnancy and associated risk with such case, and it was recommended for termination of the pregnancy. Treatment option, including the operative one, were discussed with the patient, and medical treatment was also offered to be used with any of the operative option. She desired to repeat the scan for verification of cesarean scar pregnancy, as this pregnancy was highly desired, if not a cesarean scar pregnancy. Scan repeated. So, upon her request, she was given 1 week apart and scan repeated at 8 weeks, which also confirmed that there is cesarean scar pregnancy implanted in her previous cesarean scar and had trophoblastic tissue extended within 1.5 millimeters of the anterior uterine wall without evidence of invasion into the bladder. Again, this was discussed with the patient and wished to proceed with the treatment at time. Although she did not plan future fertility, strongly desired to avoid any surgical intervention or treatment. So, we recommend the medical treatment plus or minus the surgical management jointly, depending on the availability of operating room, desire for cervical preparation, preference to end fetal cardiac activity prior to procedures. So the plan was to end the viability of the baby and then to proceed either with the medical or plus or minus the surgical intervention. Systemic methotrexate was not available, which is usually used to be used is the systemic methotrexate, the injection. So we discussed with the patient the option whether to try the oral methotrexate or to be transferred to higher center, and she preferred to use the oral methotrexate. Upon this, the patient received 60 milligram per meter square of methotrexate, and here is the follow-up chart. Let it me be clear for you. This is day 0. When I say day 0, this is the day when we administered the oral, when she receives the oral methotrexate. Beta HCG was 4,500 and day 4 was 5,100 and day 7. So there was a slightly increase in day 4 and reduction in day 7. However, the reduction was less than 15%. Renal function, liver function were all normal, and this is one of the most important things before administering the oral methotrexate. Patient was vitally stable. That is why she fulfilled the criteria to be offered medical treatment for such case. There was no concerning symptoms. Patient was vitally stable. TVS confirmed. The viable scar pregnancy with crown rumblings 8 weeks plus 4 days, and positive fetal heart is still on day 7. There is positive fetal heart. So further plan discussed with the patient and the need for further dose of methotrexate 6 milligram per meter square was given to the patient. And here we go with the follow-up. Before administering the second dose, we made sure that renal function, liver function are within normal and patient vitally stable, and there is no any concerning symptoms. TVS done in day 0. That when I say day 0, I mean the day 4 second dose of methotrexate. Fetal heart was still positive, and the beta HCG level was 4,670. Day 4, there is a drop, and in day 7, there is remarked drop in the level of beta HCG. According to that, she was planned for weekly follow-up of beta HCG. 1 week later, she presented to ER complaining of abdominal cramping and vaginal bleeding. She was vitally stable. TVS revealed incomplete miscarriage. So she received sublingual misoprostol, 600 microgram. Later during the day, she developed severe pain and expelled product. Adequate analgesia and rehydration fluid were offered to stabilize the patient. She expelled all products, after which she received 1 dose of intramuscular methergine due to risk of vaginal bleeding, after which she received 24-hour course of oral methergine. She was monitored in the hospital overnight with minimal bleeding, and she was discharged 1 day later after confirming complete miscarriage evidence by TVS. I will just show you the picture. 3 weeks later, urine pregnancy test was negative, and there were no complication. Histopathology confirmed product of conception. Patient counseled about contraception, and she was offered subdermal implants. This is the picture of, where is it? I'm lost or what? Yes. This is an empty uterus with very clean and clear, nice endometrial line. Still, uterus was bulky. So, methotrexate, just to have information about what does methotrexate and how it works. Methotrexate is chemotherapeutic agent acting as anti-neoplastic, anti-metabolic with immunosuppressant activity. It is used in gynecology, was first reported in 1956, where it was used for treatment of patients with choriocarcinoma. It works by blocking the DNA synthesis. It works by blocking the folic acid binding site and enzyme dihydrofolate reductase. This is the way methotrexate work and how fetal heart become negative, and it kill or it stop the viability of the trophoblastic cell. So this was an example of caesarean scar pregnancy, which was successfully treated with oral methotrexate and misoprostol without need for surgical intervention. Although most of the study confirmed the role of systemic methotrexate, and this is what usually we all use in hospital, the systemic methotrexate in the treatment of caesarean scar pregnancy, there are some studies supporting the use of oral methotrexate. There is cross-sectional study using secondary data obtained from medical record office on patients with ectopic pregnancy, including total of 35 patients who fulfilled the criteria for medical management. They were prescribed oral methotrexate with a dose of 60 milligram given 3 divided doses every 2 hours. It is very clear here the use or dosage is different from what we use, and this is clearly reflected by shortage of studies in this area. Follow-up was done for day 4 and day 7, and beta-HCG achieved less than 20 international units. Success rate was 82% without need for other intervention. The side effects of oral methotrexate were well tolerated by all patients without support of condition of current, which is supported by the current condition. Advantage of using lower dose of methotrexate include the reduction in the side effect of methotrexate and folic acid rescue. So this was not needed. Another advantage of oral methotrexate over intramuscular methotrexate is that the administration via intramuscular route triggers pain and local reaction to surrounding soft tissue. Furthermore, oral methotrexate is more cost effective as we need less equipment and expertise. To conclude all what we said, the inaccessibility to parenteral methotrexate has opened a new horizon to find out other options which will benefit more women in the future. Oral methotrexate can be used successfully to treat ectopic pregnancy, and there are few advantages over intramuscular methotrexate. This case report opened the way forward for more work up on the use of oral methotrexate and development of more guidelines to support providing good clinical treatment with minimal facilities available and less side effects. That's all what I have. Thank you for listening.
Okay, I'm Dr. Pablo Bashir, MD Sudan, membership RCOG, associate professor in Elgadarif University, and I'm working in King Fahad Hospital at Al Baha, Saudi Arabia, as a specialist OB/GYN. Today I'm going to talk about a study that was conducted in Elgadarif Maternity Hospital from period of January 2016 to January 2017. It's about the alternative management of magnesium sulphate regimen using 12 hours instead of 24 hours in women with severe pre-eclampsia. So as we know, many women are still dying, especially in developing countries, from eclampsia and preeclampsia and the complication of hypertensive disorders in pregnancy. There was global effort by reducing this number to 75% by the 2015. But still there is ongoing this about 28,700 women died in 2010. 90% of these occurred in developing country, like Africa, Sub-Saharan area, including my country, Sudan. So the risk factors for eclampsia and hypertensive disorders, there is no specific theory in this, but all now they are going with that. It could be immunological causes, could be cardiovascular causes, inflammatory changes. It could be abnormal implantation and decidualization of the placenta, in addition to the environmental causes and genetics and nutritional factors. Eclampsia has many complications from hospital, increased hospital admission until reaching the maternal death. So prematurity, low birth weight, placental abruption, pneumonia, heart failure and pleural effusion, seizures, strokes, liver and kidney damage, fetal growth restriction, and death to the mother and baby both. As we know, there is magnesium sulphate drugs that acting in cell membrane, preventing the actin-myosin action, and this is by many procedures from preventing mainly by preventing the calcium channel blockers to act on the muscle contractility. Magnesium sulphate reduce seizure, and it's not preventing the occurrence of the first seizure. It is not abrupting the seizure, but can prevent the occurrence of the first seizure. It is a prospective interventional cross-sectional hospital-based study. It was comparative study. We have two groups, one of them receiving 12 hours magnesium sulphate and the other received 24 hours of magnesium sulphate. The study A, it was Elgadarif Maternity Hospital. It is a hospital in Elgadarif State. The capacity of the hospital 200 beds with average deliveries 9,000 delivery, about 9,000. Eclampsia patient estimated by 5 in 1,000. And our objective that is to compare the use of magnesium sulphate 12 hours versus 24 hours. As we know, in developing countries, we have no availability of the infusion pumps, availability of the monitoring of the magnesium sulphate in blood, and we have lack of staff, nursing, and follow-up. So the idea is to reduce the magnesium sulphate infusion. By that, we can reduce the mother complication regarding the magnesium sulphate. So the study period was from 2016 to December 2016. The study population, all women in Elgadarif Maternity Hospital and diagnosed with severe pre-eclampsia during the study period, and they agree for the study. The inclusion criteria, severe pre-eclampsia, and women who agree to join the study. Exclusion criteria, women who are rejected to join the study. The sample size was all patients, as we said, that diagnosed with severe pre-eclampsia. The diagnosis were by clinically and biochemical diagnosis. The data variable was demographic characteristic, parity, gestational age, mode of delivery, and magnesium sulphate dose itself. A method of data collection was by a questionnaire from the patient, hospital record, staff interviewed, and in which the selection of the patient was by randomized selection method, include all patients that present to the labor room, ER, and outpatient clinic. Consent was given, explain the method of the treatment, either 24 hours or 12 hours. The patient who are admitted in the HDU also involved in this. Catheterized patient, magnesium sulphate was given, and the rate of magnesium sulphate was given by the international form, 1 gram per hours. It's just either 12 hours or 24 hours in each age group. Data analysis was computerized program, and the result presented in table and per graph. The research concepts are obtained from the ethical committee in Elgadarif University. So regarding the results, this is shown first graph showing the distribution of women according to the age group. We have an observation that the prima gravida are the majority of our patients, and this is also going with the natural guidelines for this. International guidelines. The other one showing distribution of women according to the parity group and magnesium sulphate hospital. We have prima gravida were 30 and multipra were 12 in the groups that receiving 24 hours, while in the other group 29 and 18. There is not so much difference, and the p-value was less than 0.005. In the other group, there is showing the other table showing the distribution of women according to the mother to the baby contact. This is what's the most important finding. We find that women who receive 12 hours magnesium sulfate has the fastest baby-bed contact with their baby, and it is started even before the 12 hours. And while the women who having the magnesium sulfate at 24 hours, they have a delay in contact with their baby and reach more than 24 hours. Regarding to the women also removal of the catheter, we remove the catheter in all women using 12 hours by 12 hours after finish of the magnesium sulfate, that we enhance air immobilization. And this also help us, as we know that air immobilization decrease the risk of wound infection and in case of cesarean section or even episiotomy in vaginal delivery, and decrease the risk of venous thromboembolism. While in cases who receive 24 hours, we find that there is delay immobilization up to 24 hours and even later. There is a small groups, about 2.8% in the 12 hours who didn't remove the catheter because they have complications regarding the eclampsia itself, polyuria, and they managed by the nephrologist, as well as the group received 24 hours of magnesium sulfate. Regarding the antenatal care results, we found that there was no difference between that patient who was booked with us or unbooked. And regarding the mode of delivery, also there was no change in women who receiving 24 hours or 12 hours. All we are based on the criteria of the delivery by the criteria of severe preeclampsia itself. Okay, this is a chart distributing the blood pressure on arrival in women. We find that women who receive 24 hours, they have had blood pressure in 70%, and women who receive 12 hours, they were 72%, and this is all randomized, and also there was no significance. So a systemic review has compared the pregnancy outcome in the case of magnesium sulfate presentation in different countries and showed that magnesium sulfate could reduce the maternal mortality and occurrence of convulsion, repeating convulsion, and major morbidities in all of the countries. In this prospective trial, we have found that 12 hours magnesium sulfate in cases of severe preeclampsia is associated with clinical course of similar to that of traditional 24 hours of blunt treatment, significantly reducing the duration of magnesium sulfate exposure and need for intensive nursing care. In the present study, magnesium sulfate administration for duration of 12 hours after delivery was effective in preventing convulsion in 49 women with severe preeclampsia, except one. There was one case developed a convulsion, and we continue hard for 24 hours. In the present study, magnesium sulfate, just one had a convulsion, and this is compared with the 24 hour is the same. Shortening duration of magnesium sulfate prescription after delivery in cases severe preeclampsia and eclampsia can reduce the risk of magnesium sulfate toxicity and its adverse effect, and as well as economically beneficial, especially in developing countries. As we said, we have many challenges in monitoring the patient with magnesium sulfate. Therefore, it seems necessary to perform studies for the finding minimum duration and dosage of magnesium sulfate in order to prevent convulsions after delivery. Using various regimens of magnesium sulfate prescription has been studied during past years. However, up to now, there is no consensus in the optimal duration of the administration after delivery and changing in the present policy for 24 hours to 12 hours. So we have also not enough study to establish this protocol. In 2006, two methods of 12 versus 24 hours administered magnesium sulfate after delivery were compared in cases with mild preeclampsia, and no cases of serious complications was reported in the 12 hours groups. Also, in another study, 70 cases was using magnesium sulfate for 20 hours after delivery in cases of stable severe preeclampsia was evaluated, and it was compared with the standard method of 24 hours duration. Clinical outcomes were similar between the two groups of 12 hours. In cases of eclampsia were reported, and there was no necessary to restart magnesium sulfate, but in 3 patients out of 60 patients, there was necessary to administer magnesium sulfate. This study was conducted in South Africa. In the present study, 1 of 50 patients had convulsion, and we continued the magnesium sulfate another 24 hours according to the magnesium sulfate international protocol, continuing for 24 hours after delivery or convulsion, whatever the last. But at the same time, 49 women have no serious complication compared with whom received 24 hours magnesium sulfate. Notice that the number of the convulsion can occur in 24 hours duration as well. So with respect to the previous studies and the postulacy of researches about the magnesium sulfate administration after delivery in this case, severe preeclampsia, it seemed necessary to perform more studies in order to find exact criteria to differentiate which patient who can receive 24-hour duration of magnesium sulfate administration and which we can give 12 hours and no need to continue for 24 hours. That we can minimize the complication, especially in developing countries. Also, it has to be studied that which group population is harmful to discontinue magnesium sulfate in shorter duration. In my study, the sample size was small, which is about 100 cases. So we need more study in bigger sample size to strengthen this theory. So magnesium sulfate appreciation in patients with severe preeclampsia was associated with less drug exposure, similar outcome, benefits such as reduction in time the mother can start contact and handle her baby, decreased time of HDO admissions, and monitoring, as well as decrease the staff exhaustion, ensure early mobilization and removal of the catheter, and decrease time and contact and cost to the hospital stay. So regarding this study, either said further study should be conducted to establish this theory. Magnesium sulfate could be the leading cause of death in cases, especially in developing countries. So more studies regarding ways that can decrease the complication should be performed. Thank you. So I'm going to present a study is conducted, effect of intrapartum maternal oxygenation on umbilical pH. This study conducted in King Fahd Hospital at Al Baha. So as we know, we are using to administer maternal oxygen in intrapartum, and it is about either for resistin technique or if the patient have suffering from hypoxia. We found that maternal oxygenated medicine may range from minutes to hours that might reach 78% of duration of labor. It was reported that oxygen supplementation was used to improve fetal acid-base metabolism or suspicious fetal heart movement pattern, that what we are used to do in our labor room. While the American College of Obstetrics and Gynecology indicate that there was no evidence of maternal oxygenation, as well as RCORE guidelines, they have a study that shown there is no effect of maternal oxygenation on umbilical pH. Another study reported on oxygen administration improved category 2 fetal heart rate tracing that may be correlated with fetal hypoxia and acidemia, leading to maternal hyperoxygenation and promoted oxygen transfer from the placenta to the fetal circulation. It was a retrospective study with Obstetrics and Gynecology Department, King Fahd Hospital at Al Baha. It is a period of 3 months in Saudi pregnant women. The participant age was 18 and above. Inclusion criteria also would be pregnant women resident in Al Baha, attending Obstetrics and Gynecology Department, King Fahd, who received intrapartum maternal oxygenation, and they agreed to join the study. Exclusion criteria was a patient who didn't meet the inclusion criteria and who refused. It is a sample size technique in using the sample size. It is a convening sample size was collected from obstetrics and gynecology, as we said, in the intrapartum period. So the study tool, it was a retrospective study conducted among the Saudi pregnant and who are using oxygenation for any type of use, either maternal resuscitation or fetal resuscitation. Recorded patient that was depend on the age, maternal status, educational level, and employment status. This is our questionnaire. In the ethical concentration, ethical approval was obtained from institutional review from the Saudi board before the data collection. Statistic analysis was using computer using IBM SPBS version 22AB, and lower value was 0.05 B value. So there was 192 women, including our final analysis. All patients were admitted to the hospital in active state of delivery and were put in oxygen flow during the intrapartum period. Mother had a mean age of 31 years old, 0.4, and the characteristic of mother are shown in table 1. The obstetric history of the mother and qualitative demographic are shown in table 2. I will show you table 1 and table 2. The obstetric history of the female, including gravity, parity, mode of delivery, Apgar score from 5 to 10. Where is the educational living umbilical condition belong to the qualitative demographic, and largest population of the female was 29, reported 1 parity, spontaneous vaginal delivery were 54, and suffer on medical condition were 45. The correlation between the intrapartum oxygenation amount and the outcome of the fetus, including the mode of delivery, Apgar 5 and 10, were investigated. In table 3 and 4, the mean amount of oxygen has significantly influenced in the mode of the delivery. B value, it was less than 0.0001, and Apgar score in 5 was 0.001. Significant positive correlation were found between the mean of oxygen amount and the each gestational age and weight to the fetus and pH in table 4. I will show the tables. So this is what the table 1 showing the distribution between the age oxygen amount. If you look here, we find that there was no big difference in standard deviation and a mean and a max. Table 2, I think it is not too clear for you, as it was showing the gravity and parity. All there was no big difference in the administration oxygen or no. So regarding the duration of oxygen supply, there were significant correlation between the duration of supplying oxygen and mode of delivery, Apgar 5 and 10, and this is will show in table 5 here. So if you note this in table 5, you will see there is a significant difference between the mean of each. This is, I think it is clear, big difference. Okay, so okay. So regarding resuscitation of the newborn in the fundamental approach in the delivery room is ensuring maintenance and quality of life. More than 1 million neonates annually needed resuscitation. It was indicated that 100% oxygen supplementation during resuscitation may be harmful due to oxygenation failure that can affect possibilities of the several disorder of the newborn, including simple like apnea and even dangerous like retinal detachment and alveolar injury. It was found that 21% oxygenation was associated with lower rate of neonatal mortality. The analysis of the umbilical cord gas is an indicator for fetal acid-base balance and fetal response to the birth stress. In the current study, we investigated that oxygenation characteristic and their impact on the mother and the fetal outcome. So, in this study, the oxygen amount was assessed in liter. We measured the oxygen amount by liter, and the oxygen duration to exposure was measured by minutes. The mean oxygen amount was 7.4 liter, where the duration of oxygen supply was 30.32 minutes. Regarding the amount of oxygen, the mean of the amount is significantly associated with mode of delivery and Apgar score 5. The highest mean value of oxygen amount was significantly associated with the spontaneous delivery, that's 7.3 liter, and higher Apgar score. Regarding the neonatal outcome, the mean outcome of oxygen was significantly and positively associated with gestational age. Yes, that's what I mean, that the larger gestation in near the term, the less the complication to the baby. The weight of the fetus also, the bigger the weight of the fetus, the less of the complication and the pH. This means that increased amount of oxygen is significantly associated with increased pH. The duration of oxygen also is associated with mode of delivery, Apgar score 5 and 10. However, the longer duration of oxygen was associated with lower segment caesarean section and lower Apgar score. So when we find that longer duration of oxygen, that means the patient has long labor or there was fetal distress. So that's why there was longer exposure of oxygen, usually ended by caesarean section, and usually by that there was low Apgar score. On the other hand, the duration of oxygen supply had no impact on neonatal outcome, and that approves the RCOD and American guidelines. demonstrated that there was a significant correlation between the level of oxygen and the umbilical cord, so the partial oxygen, the mother and umbilical cord of pH value. Another study was conducted that on 2 groups of mother to assess the effect of administration of maternal low flow oxygen during the second stage of labor umbilical cord pH. One group received a flow rate of 2 liters per minute and other received same supplementation of nasal cannula. The study revealed that umbilical cord pH wasn't refined. Between the 2 groups, another study reported that oxygenation during second stage of labor was significantly harmful to the baby. A randomized controlled trial conducted in 86 females demonstrated that the group of female who received oxygen showed a considerably lower pH of the umbilical cord of less than 7.2 compared with the control group. In our study, the amount of oxygen supply has significant positive association with the pH. The pH is increasing in the increase of the amount of oxygen. However, the oxygen supply can be limited to lower amount to avoid any increase in the pH. So that if we give low flow of oxygen, this will be less communication to the baby and may affect positively to the pH. In one study, it was found that the threshold of pH for adverse neurological outcome was 7.1. And ideal pH of the cord was ranging between 7.26 to 7.3. Above 7, however, neonatal acidemia is weakly associated with adverse outcome. That, as we know, if the pH less than 7, it will be associated with severe acidemia. Above, it will be good. So why oxygenation is helpful in the pH, that reaching the pH at minimum 7. Oxygenation amount was associated with the mode of delivery and increased with the gestational age. As we said, we found that long labor have a long duration of oxygen exposure. On the other hand, the duration of oxygen affected the mode of delivery and Apgar, but had no significant impact on the fetus outcome, such as pH. That's when fetal acidemia, fetal hypoxia can give us bad influence in the CTG, and this is may accelerate the labor either by instrumental or caesarean section, but it does not affect on the pH itself. It seems that the amount of oxygen had significant positive outcome for mother, but it can affect the level of pH of the neonate, whereas the long duration had non-favorable maternal outcome with no impact on the fetal outcome. Thank you.
I presented the outcome of teenage pregnancy in Security Force Hospital Dammam, Saudi Arabia 2019. Okay. Background and aims. Teenage pregnancy is coming up as one of the most important social and public health problems all over the world, with varying prevalence rate. In recent years, the incidence of increasing due to early onset of puberty, early sexual activity in the girls, and a relative lack of education on contraceptive method. This study was aimed to determine the prevalence of teenager pregnancy among women who delivered in Security Forces Hospital, Dammam City in Saudi Arabia. Also studied that effect of teenager pregnancy on the gestational age, premature and low birth weight on the infant, and obstetric outcome as the mode of delivery. Objective to determine the outcome of teenage pregnancy in Security Force Hospital, Dammam, Saudi Arabia, 2019. Method, retrospective cross-sectional study was performed over a period of 3 years. Data were received from hospital record. All teenager mothers aged 13 to 19 completed years at delivery, delivered in the Security Forces Hospital, Dammam, were taken. Then, variable of teenager pregnancy and the independent variable social demography, maternal age, height and weight of the mother, and mode of delivery and weight. result. The 3 years of the 3 years period of review and security force hospital in Saudi Arabia world indicate the 4768 deliveries were conducted. Among that sample cases, there were 2013 teenager pregnancy cases, making the incidence of 4.7%. This table shows the age of distribution of a teenage pregnant female attending to Security Force Hospital Dammam in Saudi Arabia from December 2016 to June 2018. The mean maternal age of a female was 18 years, was standard deviation equal 1.4 years. The teenage female age were range from 14 to 18 years, 4.2% of the total female were the age group less than 15 years, 2.5% and 15 to 17 age group, and 70% in the 18 to 19 years age. This is the table showed the mean maternal weight of the female was 70.3 kg with the standard deviation equal to 16.3 kg. The teenage female weight was range from 44 kg. Okay, the total female weight, the weight less than 45 kg and 98.6% is the normal overweight. Table 3 show the mean maternal height of female was 165 centimeter with standard deviation equal to 5.3 centimeter. The teenage female height was range from 140 centimeters to 168 centimeter. 1.8% of total female were the height less than 145 centimeter, and 98.1% is normal height. Table 4 show the gravity of a teenage pregnant female attended to Security Forces Hospital in Dammam, Saudi Arabia from December 2016 to June 18. The majority of the teenager pregnant female, 174, that means 81.7%, had prima gravida and the rest gravida between 1 to 4. Table 5 show the gestational age of teenager pregnant female attending to Security Force Hospital Dammam in Saudi Arabia from December 2016 to June 8, 2018. The majority of 4 teenager age cases, 1,061, delivered at 40-week gestational age, while 8 delivered at less than 28 gestational age. 22 delivered at 28-36 gestational age, and 12 delivery at more than 40 weeks gestational age. Table 6 show the obstetric outcome of teenage pregnant female attending to Security Forces Hospital Dammam in Saudi Arabia from December 16 to 18 regarding the mode of delivery. Normal delivery was 1,005.3 and 19 were induced, and 41, that means 19.2% of the cases delivered through caesarean section. Regarding the birth weight category of neonatal of teenager pregnant female attending to Security Force Hospital in Dammam, 2.3% of neonatal had less than 1 kg birth weight, and 0.9% had 1.5 kg. 3.3% had less than 2 kg, 1.4 had less than 2.5 kg. While most of neonatal were the normal more than 2.5 kg, the mean of birth weight of neonatal was 2.6 kilogram, that equal to 636 gram, and ranged from 9 to 0 gram to 3.4 kg. The discussion, majority of mortality and morbidity from early pregnancy, whether ending in the childhood or abortion, is much higher in the younger adolescent. Young women, especially who have less female education, are more vulnerable to pressure for marriage or sexual relation before marriage, often with older men. Young people generally lack equal knowledge about their own development and information as to how the woman to seek help. Those who would help are rarely teenage for working with adolescent and service, which are generally designed for adult or children. Often, deter young people from getting help when they most need it. In the developed country, while there is a positive relationship between a reproductive maturation and subsequently reproductive behavior, the negative effect of young maternal age on pregnancy outcome is confounding with a socioeconomic factor. Teenage pregnancy, or at least teenage birth, occur disproportionately among with the socially and economically disadvantaged class of society. In the developing country, the situation is quite different. First, early marriage and childbearing are desired and common across most segments of society. Second, malnutrition is widespread and is sufficiently severe to delay the adolescent growth support and rise average age at a menarche by 2 or 3 years compared with a scale found in the developed country. The incidence of teenage pregnancy was 4.7 in the pregnant study. Other studies show the higher incidence in the developing country range from 8.3 to 23.4. All mothers attending the hospital for delivery were married. We did not come across any unmarried teenage mother in the study. Also, our low incidence may be due to the fact that in the Islamic country, it is a common practice for unmarried mother to go either to for termination of pregnancy or to quick for delivery because of strong social taboos preventing them to attend a large public hospital. As the number of subjects of 15 years and below was too small for statistical analysis, and as expected, majority of younger teenagers were prima gravida, 81.7%, but this was surprising to find that early 19% of teenager mothers were carrying their second or third pregnancy. This is finding suggests that teenage women have no control over fertility in Saudi Arabia and are exposed to repeated pregnancy at short interval with all its inherited danger. Poor weight gain during pregnancy in teenager was reported in several studies. In the present study, weight below 45 kilogram or height below 145 centimeter were low, reflecting on overall female well nutrition in Saudi Arabia. Regarding the mode of delivery, different in observation at present, some authors have reported increased operative delivery like cesarean section or instrumental delivery. And also in adolescent age group in the present study, 19% only of teenager pregnancy female had operative cesarean section. Regarding conclusion, in conclusion, this study showed that our teenager pregnancy rate was lower than worldwide, with some results ranging from higher rate of prematurity and low birth weight, similar to reports from developed and developing country. Like developed country, the frequency of cesarean section in our study was less than expected range. Our recommendation our study was less than expected range. Adolescents comparing are now receive the publicity they diverse every day, and unless there is an improvement in the overall. Socioeconomic situation, female literacy, increased public awareness of appropriate sex education in school, and the lifting of restriction of adolescent cross access of contraceptive service. There is no longer any benefit in the term can be expected. Effect should not be mode of improve the social and demographic environment of pregnant adolescent to improve reproductive outcome, but also to reduce the incidence of teenage pregnancy by raising public awareness, enforcing marriage law, and ensuring female education. The younger group is most at risk and should turn maximum attention of them. Thank you. Prevalence, symptoms, and factors associated with postpartum depression during COVID-19 pandemic, a systemic review. The background, postpartum depression includes various depressive symptoms that affect mother during the first year after delivery. The COVID-19 pandemic result is negative psychological impact of all individuals, include women. There were several risk factors of postpartum depression, include the previous history of depression and lack of social support. The pandemic result in social distance and increased the prevalence of risk factor for depression. They determine the prevalence, symptoms, and factors associated with postpartum depression during the COVID-19 pandemic, a systemic review. This is our objective. Regarding the methodology, the medical literature was exposed, PubMed and the Google Scholar database starting from 2020 till 2021. They include searching term where combination of postpartum depression, COVID-19 depression, and COVID-19 postpartum depression prevalence and COVID-19. The postpartum depression, COVID-19 associated factor, and COVID-19, they include criteria where full text, original articles that reported that the prevalence and associated factor with postpartum depression during the COVID-19 pandemic. The result, the prevalence of postpartum depression ranged between 11.9 to 60.7%. There were several risk factors and predict for postpartum depression reported, and they include age, history of abortion, perceived stress, older age, single status, unemployed, losing job due to pandemic, dissatisfaction with the household incoming, staying in COVID-19 suspected zone and COVID-19 suspected status, concern about the lack of hospital beds, absence of partner, and anxiety symptoms, educational level, visiting the doctor during quarantine. Regarding COVID-19 impact, the study reporting similar impact of COVID-19. One study reported there was a significant difference in the prevalence of depression between women with positive and these with negative COVID-19 test. Another study concluded that COVID-19 results in a high level of postpartum depression. The risk of non-psychotic postpartum mood, including postpartum depression, was increased during the pandemic. The COVID-19 pandemic increased the prevalence of postpartum depression Another study also reported that the prevalence of postpartum depression was higher during COVID-19 pandemic compared to before the pandemic. Or discussion, the outbreak of COVID-19 had many influence on human. One of these effects in the impact of COVID-19 on mothers. Many maternal health challenges have been observed during the outbreak of COVID-19, with the higher prevalence of maternal health problem reported among women. The COVID-19 pandemic has affected various maternal mental problems such as fear, irritability, loneliness, refuse of breastfeeding, post-traumatic stress disorder, and mother-child attachment. So it was necessary to investigate the impact of the COVID-19 pandemic on the prevalence and associated factor with postpartum depression among women. It was found that the COVID-19 pandemic had a significant impact of the prevalence of postpartum depression. This impact should be observed and confirmed by the finding reporting by the study, include the higher prevalence of postpartum depression among women with positive COVID-19 test compared to the prevalence of postpartum depression among women with negative COVID-19 test. The prevalence of postpartum depression among women with higher in the COVID-19 pandemic compared with the prevalence during the duration before the pandemic. Moreover, the COVID-19 pandemic resulted not only in the increased prevalence of postpartum depression, but also affected the psychological state of women, where the risk of non-psychotic postpartum mood and anxiety disorder was increased among postpartum women during the pandemic. Also, the study used one tool for assessing the risk of postpartum depression and reported that the COVID-19 pandemic affect the psychological state of postpartum women negatively increase the risk of prevalence of postpartum depression. It should be noted that the study determined variant cutoff for the risk of postpartum depression. The cutoff was determined at more than 9, 10, 12, and some studies did not even reported the cutoff they determined for assessing the risk of postpartum depression. Study from Ethiopia report a prevalence of 23.3% before the pandemic in 2016. The prevalence rate reported from Ethiopia was in the prevalence range reported in our study. It should be noted that the prevalence of a certain condition varies between country, and the prevalence of postpartum depression in Ethiopia may exceed the various rates reported before the pandemic, and this may require further investigation. The studies include our review reported significant increase in the prevalence of postpartum depression due to the pandemic based on the previous rate reported from their country of the study. Regarding the factor associated with postpartum depression or predicted postpartum depression among women during COVID-19 pandemic, there were several factors reported in the including study include age, history of abortion, perceived stress, unemployed, losing job due to pandemic, dissatisfaction with household income, staying in COVID-19 suspected zone, concern about lack of hospital bed, absence of partner and anxiety symptoms, immigration, persistent fever, poor social support, maternal status, concern about contracting COVID-19, certain precautionary measuring, educational level, visiting the doctor during quarantine, diagnosed with depression, family history, and different during child birth during the pandemic. However, it is obvious in our study, the review that were other factors associated with risk of postpartum depression and were more related to COVID-19 pandemic, and they represented the majority of postpartum depression predicts. were there the risk of postpartum depression that previously reported and known as predicts for postpartum depression before the pandemic were less reported and prevalence among women. This indicates that COVID-19 adding other risk factor for developing postpartum depression. Other factors include losing of job due to pandemic, staying in COVID-19 suspected zone, concern about lack of hospital bed, persistent fever, concern about contracting COVID-19, concern precautionary measuring, visiting the doctor during quarantine and different and difficult during childbirth during the pandemic. Regarding conclusion, the prevalence of postpartum depression was increased during the COVID-19 pandemic as the pandemic resulted in additional risk factor for the developing postpartum depression. This showed the negative impact of COVID-19 on the psychological health of mother that may in turn negatively affect their infant. So, continuous monitoring of risk of postpartum depression and diagnosis should be done to improve the outcome of the mother and their infant. Thank you very much.
I would like to present my paper was published in 2023. It's about the correlation between resistin and follistatin hormone with the pregnancy outcome in sample of Iraqi women undergoing ICSI cycle. My name is Dr. Alia Sajid Muhammad Ali. I'm a specialist gynecologist and infertility. Infertility. According to WHO, infertility defined as a failure to achieve a pregnancy after more than 12 months of regular unprotected sexual intercourse. The chance to achieve a pregnancy within 1 year of unprotected sexual intercourse is 85 to 90% in the first year and 90 within the second 2 years. Female and male are equal and they're responsible for infertility cause. Polycystic ovary syndrome is the most prevalent endocrinopathy in women of reproductive stage of life, with about approximate occurrence of 8 to 13%. The WHO data lead to the belief that 116 million of women are affected with PCOS globally, and its pathogenesis consists of insulin resistance and hyperandrogenism. Based on the 2003 Rotterdam criteria, we have 2 of the 3 of the following criteria can be diagnosed as women with PCOS: oligoanovulation, biochemical or clinical hyperandrogenism, and polycystic ovary morphology on ultrasound. Our first hormone we are talking about here that we take about in our research is the adipocaine resistin. Resistin is a cysteine-rich peptide hormone with a mature sequence consisting of 108 amino acids produced by adipose tissue. Resistin is an adipose-derived hormone, has a physiological role regarding its involvement in the obesity and type 2 diabetes. It's a member of a small family of a secreted protein characterized by a unique spacing of 10 to 11 cysteine residue known as resistin-like molecule. That's the role of resistin in the human body, in immunity as pro-inflammatory, in metabolism, obesity, and diabetes, in osteoarthritis expression of inflammatory cytokine and chemokine, in male and female infertility. The another adipocaine is follistatin hormone. It is an autocrine glycoprotein, is an in almost all tissue and more evolved in animals and belong to the transforming growth factor superfamily, which also including activin. Follistatin and follistatin-like protein are a member of a large family of acidic cysteine-rich secreted glycoprotein with highly homologous primary sequence. I'm sorry if I'm asking, is my voice clear? Because I'm not seeing you.
Yes, you are audible. Your
Thank
voice
you.
is clear.
Thank you. This is the role of follistatin in the human body and muscle growth as an antagonist in a respiratory epithelial cell in the male and female infertility also, and also in osteoarthritis. Resistin and follistatin level has been found to be high in PCOS patients that play a role in the pathophysiology and pregnancy status of women having ICSI cycle. As mentioned before, resistin, cysteine-rich protein from adipocyte and increase in adipocyte and circulating resistin level in the blood are significantly higher in insulin-resistant mice and genetically and or diet-induced obese mice. Furthermore, epiandrosterone has been shown to increase the resistin expression, claiming that PCOS-related resistin and androgen synthesis may be correlated. On the other hand, follistatin was discovered and isolated from follicular fluid because of its suppression of pituitary FSH secretion, when has a direct connection of LH-FSH ratio level in PCOS patients. So lately, follistatin has been counted to have a role in the etiology of PCOS, as women diagnosed with this disorder presented with increased follistatin concentration, unlikely healthy women. The present study was designed to clarify the relationship between these two hormone level and pregnancy outcome in PCOS and non-PCOS women undergoing intracytoplasmic sperm injection program. In our study, it was taken an 80 infertile couple who attended the High Institute of Infertility Diagnosis and Assisted Reproductive Technology in Al Nahrain University, Baghdad, Iraq. The duration of the study extended from November 2022 to April 2023. It was approved by the medical ethical from the institute. The BMI was measured by dividing the weight of in kilogram and height in squared meter. We divided our group into two major groups, which are PCOS 40 women and non-PCOS 40 women also. Those two major groups were also subdivided into two groups according to their BMI. Increased BMI or overweight, which are more than 25 kilograms per square meter. Normal BMI weight, which are equal to or less than 25, and also the same for the non-PCOS patient. Inclusion criteria. Women diagnosed with PCOS had at least two of the Rotterdam criteria. The age was from 18 to 40 years. Couple with mild male factor, atheno, and oligospermia, and control group. The exclusion criteria were endocrine pathology, hypertension, thyroid, diabetic, Cushing's syndrome, congenital malformation of female genital tract, women whose follicular fluid was bloody during the oocyte retrieval because of its effect on the quality, cycle with no oocyte or empty follicle, women aged more than 40, women FSH level was more than 12, and women with bad endometrial receptivity. The female investigation were general and medical examination, hormonal assay, ultrasound, and hysterosalpingograph or HICOC. For male evaluation, there was general information, include name, age, and fertility history, general and medical examination. Sperm was collected 3 to 5 days after abstinence, and semen analysis, concentration, motility, and morphology. Our study design was started by, as I say, 80 infertile couple divided into two, PCO and non-PCOS. We took the history. We take those parameters, age, BMI, type of infertility, duration of infertility. Basal serum, FSH, LH are day 2 and 3, and day 2 or 3 serum resistin and follistatin. This was the program we designed for the ICSI protocol, which is antagonist. At the day of oocyte retrieval, measurement of resistin and follistatin was done from follicular fluid and serum. The ICSI procedure And for the EGSI outcome, we measure the total oocyte, type 2 M2 oocyte, fertilization rate, total number of embryo, and we only took the grade 1 and grade 2 for embryo transfer. After 14 days after embryo transfer, we did the beta-HCG for all the patients for calculating a pregnancy outcome. These are where the devices were used for the follistatin and resistin measurement. These are the kits. This is for resistin and this is for follistatin done by ELISA. Results. We first measure the correlation between resistin and follistatin for age and BMI. Sorry. There was only a significant measurement in resistin at the day of ova pickup and follicular fluid, and follistatin at the day of ova pickup serum. Otherwise, there was no other significant between the age or BMI with the other parameters. As for the correlation between resistin and follistatin level with FSH and LH, we only find a significant difference with LH and follistatin at the day of ova pickup serum. Otherwise, there was no other significant difference. According to comparison between of resistin and follistatin level between the study group, they were all, we find a significant difference in all the 4 subgroups and the resistin and follistatin level, except for follistatin in the follicular fluid. We didn't find a significant difference. Otherwise, they all read a significant difference, and the higher group was the PCOS with normal body mass index was the higher significance between the other group. The comparison of resistin and follistatin level for pregnant and non-pregnant women following EGSI, we find only a significant difference according only to resistin at the day 2 serum and the day of ova pickup in the follicular fluid. There was no significant difference for the pregnant ladies in the follistatin level. So from that criteria, we make a cut value or a ROC value. It only includes the follistatin level at day 2 serum and at day of ova pickup follicular fluid. A cut value of for day 2 a 9.8 and for the follicular fluid 15.06. This is the ROC value according to day 2 and according to follicular fluid, shows that the area under curve that we are searching for our data and we can predict a pregnancy rate according to these 2 numbers. Discussion. For the correlation of resistin and follistatin level with different factors, the possibility of for the lack of a strong association between resistin and obesity could be that in human, macrophage rather than adipocyte are the major source of resistin, and it's related more than other factors such as insulin resistance. Serum follistatin may act as a potential screening biomarker for PCOS regardless age or BMI. In a study done, there was a different age group women and who became pregnant. They found that there was a strong relation between age, pregnancy, and follistatin, as FSH level increased with age and has a relation with activin follistatin. Also considering activin is present in the reproductive system. For the correlation of hormone FSH and LH, as the current study show a correlation between LH and follistatin blood level, while no significant correlation between other parameters, although there was no evidence of a positive or a negative impact of resistin on a pregnancy outcome, it is possible that PCOS women, the hormone may have a detrimental effect the same as LH. In fact, The structure and function of a growing follicle depend on LH. The LH peak enhances the ova to resume meiosis and reach final maturation by blocking the ova maturation inhibitor in early phase of normal menstruation. For the comparison of resistin and follistatin between the four study group, it is clearly demonstrated a significant alteration in the secretion of resistin. In lean PCOS patient compared to healthy patient, so it's likely that other factors independent of obesity affect resistin level. An increase in follistatin may arrest follicular development and increase androgen production, and these features are seen in PCOS patients. It has been reported that circulating level of resistin and follistatin were higher in women with PCOS compared to non-PCOS, regardless of the obesity status, indicating that these adipokine might be contributed to the pathology of PCOS. The rapid clearance of resistin and follistatin into the blood caused by fecal secretion of these adipokine and the abundant blood supply in this specific site of the ovary could explain this finding. For the ICSI outcome, a study done by Eddie Jelly about the effect of activin and follistatin and fibrillin, dose-3 hormone in pregnancy rate in IVF program, they found that elevation in serum follistatin in day 2 or 3 in pregnant women and continue to increase even more in luteal phase, and such finding in agreement to the result of the current study. The same observation was reported when the researcher found that a behavior of a follistatin level was exactly opposite to that of AMH level. And the interest finding when follistatin level increased significantly during the pregnancy and on the first day after parturition, but decline afterward, whereas AMS level decreased significantly during pregnancy and decreased after labor. During the pregnancy, follistatin level tend to increase due to the high demand for growth and development of fetus. It helped to regulate the action with activin, which are involved in various aspects of pregnancy, such as implantation, where the fertilized egg attached to the uterus. Analysis of ROC curve that's shown in Table 5 and Figure 1 and 2 contributed that follistatin at day 2 that more than 8.8 and in follicular fluid more than 15.06 are predictor for occurrence of pregnancy after ICSI or IVF. As a large of significant area under the curve, 69% and 68% respectively, showing a significant association between the higher level of follistatin at day 2, which is serum, of course, and in follicular fluid at the day of ova pickup getting pregnant. Follistatin at day 2, it was 55% sensitive, 81.8 specific, and 72% 0.5% accurate, while in follicular fluid was 77.8 sensitive, 67.9 specific, and 71.3% accurate. In predicting occurrence of pregnancy after ICSI, it has been stated that follistatin could be showed promising diagnostic performance, and it may be considered for further study to create a single PCOS screening method that is independent of the other diagnostic criteria with acceptable sensitivity and specificity. Conclusion. Resistin and pregnancy rate did not correlate. The cutoff point of follistatin level in the serum at day 2 and in follicular fluid at the day of a pickup was found to be a predictor for pregnancy after ICSI. Resistin and follistatin may be helpful indicator of PCOS. Recommendation: both resistin and follistatin can be measured as laboratory indicator of manifestation of PCOS, and their kit price were affordable. Additional study is necessary to evaluate the correlation between resistin and follistatin markers with a pro-inflammatory cytokine and their effect on embryo quality on poor ovarian responder patient. Study of resistin and follistatin effect on male infertility so that we can see the effect of these biomarkers. Additional research to relate changes in serum and follicular fluid of resistin and follistatin level to Doppler blood flow velocities in ovarian and in uterine blood vessel during ICSI cycle, and to assess the relation in PCOS patient compared to none. Further, defined studies with large sample size should be performed to examine the circulating level of resistin and follistatin and their role in PCOS. As you know that we took only 80 in the data. Of course, the more the better. And thank you so much for your listening. And I'm sorry for that problem happens. This is the hospital where I work. This is Kamal Samarai in Fertility Hospital. These are my colleagues. And these are one of my results. These are a pregnancy successful after primary infertility for 14 years. And this is also a secondary infertility, and there were triplets, and they are all healthy and good. Thank you for your listening, and thank you for this contribution.
First of all, thank you for the invitation. My name is Osley Dematz. I am a primary health research coordinator. And today I will present the article, The Influence of the Age at Menopause Onset on Sarcopenia in Postmenopausal Women, based on the Foundation National Institute of Health Consensus. These are the topics. So I will start by talking about women from the menopause to aging. Aging brings many physiological changes, and the menopause starts a chain reaction, which leads to the loss of bone and muscle mass. Ovarian failure promotes low estrogen, which causes increased bone resorption, developing type 1 osteoporosis, and decrease in muscle anabolism. Due to lower estrogen levels caused by menopause, women will experience changes in their metabolism and redistribution of fat from the pelvis to the waist. And this will not only cause cardiocirculatory damage, but it will also mark the beginning of major changes in their body's components. As you can observe from this graph, a lower peak in bone mineral density and more acute losses occurs to women after the menopause phase. And the consequences are higher rates of hip, vertebrae, and forearm fractures at younger ages compared to men. Aging can be characterized as a continuous progression where there is a steady decline in all physiological processes, a set of physiological events that reduce organic capacity, where physical inactivity intensifies changes in different systems. Women go through a series of changes as they reach old age, and the degree of change can vary from person to person. In relation to menopause and loss of muscle mass, the prevalence of sarcopenia may vary according to the definitions and standards established by the certain consensus. This phase is still accompanied by several modifiable factors, such as sedentary behavior and changes in nutritional habits, resulting in associated comorbidities. The decline in muscle mass throughout life can reach 50%, and only between the ages 75 and 80 can these losses reach around 25%. However, losses in postmenopause phase are more pronounced, and the consequences are lower resting metabolic rates, weakness, reduced physical activity levels, lower bone mineral density, and postural changes. About sarcopenia, sarcopenia is multifactorial, such as advanced age, disuse, endocrine, inadequate nutritional, neurodegenerative, etc. In these images, we can observe a decrease in muscle mass and a greater concentration of fat mass both in the subcutaneous and intramuscular areas. The European consensus is one of the most used to classify sarcopenia, and in 2010 presented a new classification where sarcopenia is no longer considered just a loss of muscle mass. The low muscle mass now being considered pre-sarcopenia and associated with low strength or low physical performance classified as sarcopenia. In 2019, the European Consensus published the new version, changed the classification again, where low strength is the first criterion and associated with low muscle mass defined sarcopenia, while performance test is now only used to classify severe sarcopenia. However, for the Foundation National Institute of Health Consensus, the American Consensus, the older classification with low muscle mass as the first criterion was maintained. In this way, we consider that sarcopenia is the most important modifiable variable to be assessed since menopause phase. Thus, we always evaluate body composition and then use the protocol that best applies to each population. Here we can see the DEXA scan and the protocol for performance testing. For DEXA, we analyzed lumbar spine and hip for bone health and total body composition for sarcopenia, hand grip for strength, and short physical performance battery with 3 tests, balance test, gait speed, and chair stand for performance assessment. This is the same protocol I use to verify the risk of falls in women, frail women in the healthcare unit in Brazil. DEXA exam has the measurement for the European consensus that use the appendicular skeletal mass, but we can do the foundation using body mass index as a variable. Appendicular skeletal mass is the total skeletal mass of the upper and lower limbs. For example, I worked for years with women who have undergone bariatric surgery, and in this population, the loss of muscle mass was the most evident change in a short period of time, unlike my research with postmenopausal women who showed significant loss in muscle strength. Currently, sarcopenia not only relates of bones biomechanically, but also biochemically. This evidence is supported by the European Society Working Group in this article. Therefore, I investigate of the onset of menopause in 2 phases. First, the effect on bones, on bone loss, and then on the decrease in muscle mass. In this article, the menopause group, aged 50 or less, showed a greater association between the variables and influence on bone mineral density, especially in the hip area. We then published another study on the onset of menopause, where we use the Foundation National Institute of Health Consensus for classified sarcopenia. In this case, the sample consisted of 111 postmenopausal women with an average age of 69.5 years, divided into groups according to age at the menopause, before and after 50 years. Here in this graph, we can see the different distribution profile of appendicular muscle mass in both groups, demonstrating a premature change in the loss of muscle mass in limbs. This slide shows the important inverse correlation between body mass index and appendicular skeletal mass for both groups, representing the change in body composition between loss of muscle mass and gain of fat mass. Thus, in this study, hand grip strength showed a statistical correlation despite the loss of muscle mass for the group aged 50 or less, while the waist to hip ratio had a greater influence for the group had menopause onset after 50 years. Therefore, we conclude that menopause before the age of 50 had an important influence on both muscle mass and strength. Thus, for the group studied, the use of hand grip strain as the first criterion for classifying sarcopenia proved to be more reliable. In this line, we studied the influence of variables in anabolism in postmenopausal women and evaluate variables such as sleep quality, nutritional profile, and physical activity levels. To analyze sleep quality, we use the Pittsburgh questionnaire in our study, and the vast majority of participants have fractional sleep and poor sleep quality. In this case, non-restorative sleep causes daytime drowsiness with reduced reaction speed and attention, fatigue with increased risk of falls, incomplete REM phase, which causes cognitive problems, and incomplete non-REM phase, and the loss of the anabolic phase, loss of bone mass and muscle mass, increase adiposity. We refer patients with sleep disorders to a sleep institute to undergo polysomnography for the clinical analysis of associated problems. To further develop our studies, we are now also exploring the influence of intramuscular fat on sarcopenia and performance in women using the ultrasound. Thank you all.
Good afternoon, dear colleagues. Let me present to your attention the result of research work carried out at the Department of Obstetrics of Astrakhan State University. Growth differentiation factor 15, GDF15, as a biological marker of early pregnancy loses and its relationship with markers of oxidative stress. Growth differentiation factor 15, GDF15, is a cytokine and a divergent member of the superfamily of transforming growth factor beta, GDF-beta. GDF15 contains 7 conserved cysteine residues forming a cysteine node, which is a defining trait of the TGF-beta superfamily. GDF15 is encoded by a gene located on the interior chain of the short arm of chromosome 19. GDF15 is synthesized as a peptide, 308 amino acids, alone consisting of a signal peptide, a propeptide, and a mature peptide. Circulates as a 25-kDa dimer linked by a signal interchain disulfide bond. 2000. Growth differentiation factor 15 was identified to the TGF-beta superfamily based on its definitive semicystine area and functions, regulates cell migration and adhesion, possesses immunosuppressive properties, suppresses development of monocyte macrophage lineages and their ability to produce pro-inflammatory mediators, regulates tissue remodeling and healing, regulates gene expression by and activation of SMAD transcription factors, affects cell growth, differentiation, apoptosis, and fibrogenesis, exhibits antitumor and pro-apoptotic activity. GDF15 is normally expressed in most tissues at a low level. GDF15 level is elevated in a variety of pathological conditions including oncological processes, atherosclerotic cardiovascular disease, and obesity. 1997. Chromas R and co-authors isolated GDF15 from trophoblast cells at higher concentrations and suggested that GDF15 may be a mediator of placental control of embryonic development. GDF15 helps to maintain a pregnancy by inhibiting the production of pro-inflammatory cytokine by regulating trophoblast invasion. Oxidative stress can induce the expression of GDF15 via p53 transcription factors or the early growth response protein 1. Studies using HDR8 CV neo cells and primary human syncytiotrophoblasts have demonstrated that insufficient GDF15 expression doesn't affect cell proliferation or apoptosis but impairs and extravillous trophoblast invasion by reducing IHG1 not CH3 has 1 signaling activity. The study objective: to determine the level and analyze the relationship between the cytokine GDF15 and biochemical markers of oxidative stress in women with a normally progressing and non-developing pregnancy as predictors of miscarriage at the early stages. The study design is presented on the slide. There are groups of patients who underwent research. Main group: 40 patients diagnosed with a non-developing pregnancy at 9 weeks of gestation. Control group: 40 patients referred for an artificial abortion. All patients underwent a medical history, a standard clinical and diagnostic examination, blood sampling from a peripheral vein as well as aspiration fluid was obtained from the uterine cavity and chorionic tissue during the vacuum aspiration. Exclusion group: severe extragenital disease, body mass index is more than 30, endocrine pathology, uterine miscarriage factor, antiphospholipid syndrome and congenital thrombophilus in the medical history, vomiting of pregnant woman, confirmed pathological karyotype of a fetus, pregnancy as a result of IVF. In all groups, blood serum levels of oxidative stress markers, malondialdehyde, carbonyl groups of protein superoxide dismutase, GDF15 level were studied in chorion tissues, lipid peroxidation, spontaneous, acorbate dependent, and initial. Determination of LPO rate was carried out according to the ability of phenobarbitoric acid to react with MDA in biological substrates, according to the method of ID Stalnaya, Garishvili, modified by Stroev and Makarov, 1986. Oxidative modification of protein was performed according to the method of Dubinina, 1995, based on the qualitative fraction of interaction of oxidized amino acid residues of protein with 2,4-dinitrophenylhydrazine and registration of the level of carbonyl derivatives. Determination of salt activity was performed according to the method of Chivari, 1985, based on the ability of salt to compete with nitro-blue tetrazolium for superoxide anions. The level of GDF15 was determined by ELISA using a microplate photometer. State facts: 4,200 USA analytical kit human GDF15 MiG-1 ELISA bio vendor Czech Republic with a measurement range 22 4,480 pg per mil and sensitivity 22 pg per mil. Indicators of levels of oxidative stress markers. You can see on this slide two groups, main group and control group. levels of oxidative stress biochemical markers. Determined using standard methods presented on the slide. As a result of the study, it was found that in the study group, markers of oxidative stress are significantly higher than in the control group. The GDF-15 level in BS of healthy non-pregnant women was previously presented in the works of Gosharova, where the indicator was 978.74.1 pg per ml. In the tissue of the chorion, the levels of markers were also higher than in the control group. The level of GDF-15 was higher in the aspiration fluid and chorion tissues in the study group. We show one after another. Correlation analysis revealed positive and negative connections between the level of GDF-15 and markers of oxidative stress. Discussions and conclusions. The results of the study have shown that statistically significant levels of OS markers and GDF-15 cytokine were determined mainly in the aspiration fluid and chorion tissues that confirms the theory about the role of local homeostasis and its balance for the development of a normal pregnancy and its disorders. Previously, in the work of Tong 2004, a study of GDF-15, a significant decrease of this indicator in the blood serum of women with a spontaneous miscarriage was found. As a result of our study, no statistically significant difference in the GDF-15 level in the blood serum of the study groups have been obtained. P more than 1.05. The GDF-15 level in higher concentrations was determined in the aspiration fluid and chorion tissues of the study group, P less than 0.05. That confirms the theory that trophoblastic cells are the main source of this cytokine and the theory of the local autocrine mechanical of the effect of this protein on the extravillous invasion trophoblast. The results have shown in patients with a non-developing pregnancy, GDF-15 level in the chorion tissues and aspiration fluid is lower compared to the control group. The correlation analyses have shown that during a normal pregnancy there is a positive correlation between the GDF-15 level in the blood serum and chorion tissue that allows the use of serum GDF-15 levels to assess the diagnosis of a pregnancy. A complex balance maintained between the products of active forms of oxygen and antioxidant activity with a non-developing pregnancy is shifted towards oxidative reactions. LPO processes, both enzymatic and non-enzymatic, occur more actively in patients with a non-developing pregnancy. ASCD LPO indicator is significantly higher than the indicators of SP-LPO and in LPO in chorion tissues in patients with a non-developing pregnancy. The results have shown that in patients with a non-developing pregnancy, GDF-15 level in the chorion tissues and aspiration fluid is lower compared to the control group. The correlation analyses have shown that during a normal pregnancy there is a positive correlation between the GDF15 level in the blood serum and caesarean tissues that allows to the use of serum GDF15 levels to assess the diagnosis of a pregnancy. In patients with non-developing pregnancy, the level of OS markers is inversely proportional to the GDF15 level. Increasing the level of SOD, one of the main enzymes of antioxidant protection during a non-developing pregnancy, also indicates the development of OS. Conclusion: unraveling of the signaling events initiated by OS, as well as understanding the physiological functions of the cytokine GDF15 and its role in pregnancy and its complications, are important for better understanding of the pathogenesis of a non-developing pregnancy. Currently, it's necessary to continue researches in this direction, which will allow us to move on to the next, more important stage of researching for specific biomarkers and their combination in order to improve diagnostic accuracy and its specificity. Thank you for your attention. Candidate
Hi everyone, my name is Mariana and I will be speaking about social media as a tool for women's health education. Before I even start talking about social media, I first wanted to introduce myself and let you know why I'm speaking about social media at a conference on gynecology and obstetrics. So again, my name is Mariana. I'm 27 years old. I hold a bachelor's in biological pharmaceutical chemistry from the National Autonomous University of Mexico, or UNAM. I then spent 2 years in the pharmaceutical clinical trials industry, and this was kind of during COVID and stuff like that. And after spending a bit of time in the industry, I decided to do a master's in women's health at University College London. This master's was quite special because I had both scientific and medical knowledge, but I also had anthropology, sociology studies. We observed and looked a lot at culture, stigma, traditions and things like that, and how they influence health. So after doing a bit of reflection and understanding what I wanted to do, I decided to be an Instagram and TikTok content creator on November 2023. And that is how Ciencia con Mariana, which means Science with Mariana, started. The goal of this entire project is to spread information on hormonal health, including sexual health, reproductive health, menstrual health, women's health in general. And also, I call it hormonal health because sometimes I will also talk about, for example, insulin or, for example, melatonin and the effects that they have on different situations in our body. So, not to diminish the things that I've done in the research and the time that I've spent editing and doing videos, but with the numbers that I have, I think one can understand how powerful is social media. So on Instagram, I now have almost 3,000 followers, and on TikTok, and this one's insane to me, I almost have 63,000 followers. So this is the proof, or this proves that people want to know about health situations and they want health education, and even more when it's about women's health, because it's so surrounded by stigma and a lot of misunderstandings and a lot of misinformation. So now why social media is so important? In order to understand that, we need to understand the global context that we're living in. So I think this one's quite obvious, but we lived in a globalized world. If this wasn't true, then I wouldn't be able to be sitting right now in Mexico City, given this conference at something that was in person in Thailand. But I know that a bunch of you are seeing this presentation from many different places around the world. We also live in a digital era. That one could also be quite intuitive, but something really important about this digital era is that it's really fast paced. So it's moving so much, and even more now that we have artificial intelligence, you might have come across or have noticed how fast it's growing since that moment. So this also makes us want things faster and want things like right away and easy to understand. And some numbers here: 5.44 billion people are internet users, which means that is 66% of the global population, which is a gigantic amount of people. From those 544 billion, 5.07 billion are social media users. So basically most of them. From those, 1.7 billion are users on TikTok, 2 billion are users on Instagram, and although I don't use YouTube, this one's also quite popular. 2.49 billion people are users on YouTube. Other social media pages can be, for example, Facebook, and I'm sure there are many more that could apply to the different contexts you come from. So now, something that's also important to consider, taking that global context into consideration, is the health digital evolution we're living in. So this is something that I actually learned a couple of months ago when I started this whole social media situation. Young people, I know I'm young, I'm 27, I know I'm young, but I'm referring to people that are probably 20 or less. Young people now use social media as a new Google. So, for example, instead of going on Google and searching what PCOS, they will probably go on TikTok, search what PCOS, and then find a gigantic amount of information that can go from people actually explaining what PCOS to people that have PCOS telling their experiences, to people talking about treatments, to people about talking about contraception, for example, etc., etc., or even like the food that they eat because they have PCOS. Also, something that maybe COVID helped a little bit doing was moving the health world into an online world. So it because of COVID, we started having online consultations, we started having these webinars, we started having everything inside a computer, which also focuses education and health towards the online world. And then finally, people don't want traditional education anymore. Sorry, that says want, but don't want traditional education anymore. So, because we have this digital era and we have this fast moving situation, people want that. People want to be updated in a bigger way that doesn't involve the traditional ways that we would implement education. So, considering all of that, why is it powerful? Social media has this term that's called engagement. It's actually so important that even when you collaborate with other businesses or with other accounts, the first thing, or maybe I don't know, within the first 5 questions that they make is what is your engagement, which is like an actual number. But it's also a word, which means that you are engaging with people. And from the other side, or really related to this, we have that it's relatable. And I think this is one of the most important things about social media, and the most important thing that you can do if you decide to open a social media account, is that you have to be relatable. You might think, well, I'm a gynecologist, how am I going to be relatable to my patient? Well, you can, through your personality. So when I'm speaking the way that I'm speaking, I'm moving my hands the way that I am, I'm using different cues, different colors inside my presentation, that is making you already have a certain association, or a certain, you're already making assumptions about how's my personality. And that's what happens within social media. And you don't have to show your face in order to do this. You can also make posts, you can also make videos that don't involve your face or don't involve you speaking, but that are presenting your personality, which is making people be like, oh, she's actually a human, she's not a Google text that is explaining PCOS, for example. So that's why we are using audiovisual tools. So social media is no longer only about like dances and music and things like that. It's now involving much deeper topics. Also, we have user involvement and retention, which is so easy to do in this platform. You can now have feedback right away. Once you post a video, you will have feedback on if people understood what that concept you explain is, if people have questions about that topic you explained, and they will also retain the information the way that they can. So something that happens in traditional education is that sometimes some people take a longer time to understand the concept, and within social media people can watch the same video a million times until they understand it. And then one that may be quite intuitive and obvious is that we have less geographical limitations. So for example, even though I'm in Mexico, I also have followers that are from Spain and that are from other Latin American countries, for example, Peru, Guatemala, Colombia, Bolivia, and I'm probably missing a few more, but those are the basic big ones, which is still fascinating to me that I am doing videos inside my house and are being watched in different parts around the world. Now, why use it in health? So the first point that I have here is one that I actually don't implement because I'm not a medical doctor, but I do have a lot of friends and a lot of new collaborators that I've now contacted and have known because of this whole thing that I'm doing, that is that you can have an influx of patients. And it's not only important that you can have more patients because you have social media, but also the fact that you can engage with the patients that you already have and create a better community with your already really known patients. So whatever situation you want, if you want more patients or if you want to create a community with the ones that you already have, this is a great tool because you're creating trust. Once again, we go to this relatability, to this engagement situation where I don't know if this is true to every country you're from, but for example, here in Mexico, the public health system has consultations that are 5 to 10 minutes long, which means that if someone wants to tell you their full symptoms and maybe their full story and their full life situation, they won't be able to do that, and they will probably miss a bunch of things along the way, which makes their life more difficult and also your life more difficult. Also, because we're talking about women's health here and also about gynecology and obstetrics, we have a lot of stigma, we have a lot of misinformation, we have a lot of taboos within this world, which also implies that maybe a lot of people won't tell you all of their symptoms because they're afraid to tell you, because they have all of these cultural and traditional and stigma relationships and connotations to the symptoms that they have. So if you create trust through the social media platforms, you will be probably able to have your patients be like, oh, actually, I have this painful thing going on, or I don't know, talk about their sex lives with you, because you're creating this trust. Also, you can just educate the way that I do. My purpose is just to create a platform where people can understand things. And finally, that's something that's really important. If you decide to do something with social media, it's really important to translate complex information to terms that they understand. It's actually a really good exercise for people that now are healthcare professionals. It's a really good exercise because it also reinforces the concept inside of your own head, and it also helps them understand concepts that, I mean, you don't have to explain, for example, a certain gene to the most complex thing, but you can explain what genes are, or you can explain what inheritance is, or why it's important in order to know, I don't know, for example, how perimenopause is going to happen. And all of that, it goes to one single thing that is called body literacy. I don't know if you're familiar with this. It's a quite easy concept to understand. Where basically what I want to create and my main motivation is that I want people to have body literacy. This is because I believe people deserve to understand how their bodies work. So I think it's horrible and it's quite scary that millions of people around this planet live in a body that they don't understand. And this is much more related, again, to gynecology and obstetrics. For example, people don't know what menstruation is. They have no idea what this blood looking fluid is, where it comes from, what it means, why it's happening every single month, uh, why it stops sometimes. They also probably don't know what their uterus is. Some people don't know what the ovaries are. And even if you explain to them in a consultation quickly, like, oh yeah, they're right here, and like they ovulate, sometimes we get so caught up in our medical scientific environment that we forget that we were once in a position where we had no idea what an ovary or an uterus was or what pregnancy was. um, so yeah, I also believe that if people know how their bodies work, it will be easier for them to understand when something's wrong. So if people know what, for example, menstrual cramps are, they will understand when they're out of control and the pain is too much, and they should probably seek a medical provider or a medical professional. um, and and yeah, because I think there's a lot of people that also don't know what's normal and what's not normal, and then they don't know if they go seek medical attention, if they will actually be shamed for it or bullied for it, or they'll, I don't know, ashamed for it, because they don't know if this is something that's a common thing or not. And once again, we go back to my favorite word, and it's trust. So I also believe that if people have body literacy, then you can have a better conversation inside a medical environment. So if I understand what my uterus is, and you tell me that, I don't know, I have endometriosis, which means blah 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 blah, then that will make much more sense to me, because I know what a uterus is, and I know what an endometrium is, and I understand these concepts, and therefore I'll probably be a better patient when I'm treating, when you're treating this with certain things, or if you explain treatments to me, it'll probably make more sense because I know how my body works. I hope that makes sense. But in order for that to happen, I really, really believe that language is a gigantic barrier, and I am quite sure that a lot of people here are not native English speakers. For example, I'm not, and that is that it's a huge barrier because most information is in English. For example, this conference is being held in English, even though most of us speak different languages. Also, most scientific papers are in English. But to this, I would also add that even if you're an English native speaker, you probably don't know how to read a scientific paper. We all know here how difficult they can be to understand, and also how difficult it can be to know how reliable and accurate they are. So that is out of the question, and we also remove a bunch of people from this world. So, for example, you wouldn't ask your patient that has PCOS, oh, just go online and read all of these 50 scientific papers on PCOS. But anyways, going back to English, most health content creators speak English. So I have found that a lot of people talk about menopause and talk about pregnancy and talk about all of these menstrual situations and, for example, cardiac health uh, issues, but they're in English. So I think that creates a huge barrier for millions of people around the world. And although English is the most spoken language around the planet, not everyone speaks English, and also not everyone has English as their native language, which I think is essential when we're creating body literacy, because it will be much more easier for someone to understand what all of these things inside their body are if you do it in their own language. Also, because probably if, I don't know, I explain to my patient in English what the uterus is, but then, and I don't know what LH is and FSH is and progesterone and estrogen is, but then they go one day to the doctor and they obviously speak in Spanish, for example, then maybe these concepts will make less sense. I hope that is quite understandable. So that is why I also decided to do my page in Spanish, because also, I mean, Spanish is quite a spoken language. But even if it wasn't, even if I had, even if my native language was, sorry, even if my native language was one that isn't as spoken, I would probably also do it in that one. But anyways, probably everything sounds like it's magical and it's great and like it's a fantastic idea, but unfortunately, we also have some dangers within the social media world. So, one of the biggest issues, which can be a good and a bad thing, is that anyone can post anything. So, unfortunately, we will encounter people that will talk about health and medical issues but have absolutely no degree in that or cannot demonstrate that, or also people that don't give sources and can be quite scary and quite dangerous. Because another situation that we have within the social media environment or world is fear mongering. So as an example, and quite a really popular one, now a lot of people are scared about pregnancy, and one of the biggest reasons is that they go to TikTok or they go to Instagram and they have all of these people talking about their horrible experiences with pregnancy or their horrible experience through labor, and saying that all of these medical interventions were done to them and that, I don't know, they almost died and things like that, when they actually have a condition that isn't that common, for example. So then a lot of people are having all of these experiences that might not be as common, and they're just creating more fear, which I think this is where we can also intervene and explain how common these things are and how true or not are these different experiences that are happening. Something that can also be create quite a problem is the cancel culture. So it can be scary as a content creator to make content because you might be scared that they cancel you in the rare occasion that you say something that isn't true or that you weren't aware that has, I don't know, an update or something like that. That hasn't happened to me, but I know that can be a bit scary. So the way that I help a bit with this is that I always make content backed up by science. For example, even if I'm talking about some sort of contraception that I've studied a lot, before doing the video, I go once again into papers and I research a lot of it and have my resources ready in case someone asks where I got this information from. This especially happens when you're saying something that can be quite impactful or that it can break some of the stigma or some of these taboos that have been related to these certain topics. And yeah, finally, just give sources when they ask for them. Another thing that I do is that I either put them on the post, or for example, if it's a video, I'll be speaking about something and they will just like appear the different titles of the papers that I'm using. But anyways, just to finalize, I do believe that social media is a fantastic tool for health education, especially women's health education. I think it is breaking a lot of stigma. It is breaking a lot of taboos. People, you have no idea how many people comment on my videos like, I had no idea this was a thing, or finally someone explains it to me. So I encourage you to try it if you really want. And well, basically that's kind of it. I think my image is sorry. I think my image is making you not be able to look at my email, but my email is there, which is cienciaconmariana@gmail.com. It's the same as my username, and please send me an email if you have any more questions. And thank you very much for the attention.